Recording in progress.
Keep the mask on. You can take it off. Okay.
Good evening, in the name of God, on behalf of Persian Orthopedic Trauma Association and Iranian Orthopedic Association, we start the elbow and forearm session of the first international webinar of POTA. Special thanks to our international lecturer, Dr. McKee, Dr. Hauseman, Dr. Blonna, Dr. Muller, which all of them kindly accept our invitation, and we are so glad to have you with us tonight. This session is consisting of two parts. In the first part, we will have 4 lectures, and after this 4 lectures, we will have a time for discussion session. Our first lecturer is Professor McKee from the United States. Dr. McKee, as I wrote you in my email, every Iranian orthopedic surgeon know you, and in every single orthopedic meeting in Iran about upper extremity, your name is heard. Dr. McKee is a world-renowned orthopedic surgeon who has received numerous awards and distinction for his research in orthopedic trauma. He is appointed as the Department Chair of Orthopedic Surgery of College of Medicine in the University of Arizona, and he is one of the main authors of right foot textbook that is completely familiar to all orthopedic surgeons in Iran. The topic of Dr. McKee's speech is about the management of elbow dislocation and associated lesions. Dr. McKee, eagerly we wait to hear from you. Please start.
Thank you very much, Dr. Bagheri. Can you see my screen okay?
Yes.
We're good.
We have your screen.
All right. I'd like to start out by thanking you, the Persian Orthopedic Trauma Association, very much for the invitation to speak at this meeting and join such a stellar cast. And I thought I'd start out talking about elbow dislocations and associated lesions. And I think this would be a good basis for some of the other talks that are going to go on here today. My disclosures are up to date in the American Academy website, and I'm a designer of some plates around the elbow, so it's important that you recognize that. I think if you look at the main constituents of elbow stability, there's the bony processes that include the coronoid process and the radial head, and they're the primary bony constituents of elbow stability. So those two things are critically important for elbow instability on the bony side. If you look at the soft tissue structures, there's the medial ulnar collateral ligament, which inserts in the medial side, as we know, and is very important for throwing. And it does play some role in trauma and post-traumatic elbow instability, but perhaps not as much as the lateral side, which is probably the more dominant ligament for elbow stability. And it's been characterized as the lateral ulnar collateral ligament going from the lateral procondyle to the tubercle of the supinator crest on the lateral side of the elbow. So these four things are critical for elbow stability. Roughly in order of importance, that the coronoid is most important, the lateral collateral ligament, the radial head, and then maybe finally the medial collateral ligament of the elbow. But those four things are what you need to think about when you're talking about elbow stability. And this is roughly the order that most authors would put them in terms of importance. Dr. Morey talks about the primacy of the coronoid. It's the most important thing. And then we go down the chain for elbow stability. So these are the basics to keep in mind for all the talks today. Most simple elbow dislocations, and by that I mean a closed dislocation with no associated fractures, can be treated quite well non-operatively. So usually a closed reduction is done either in the ER or in the operating room, depending on the difficulty. And once you have a closed reduction that's successful, there's pretty good data that most of those patients don't require surgery. One of the earliest randomized trials in elbow area was done by Josephson back in 1987, and he randomized patients with simple dislocations to surgery or no surgery, and really found there was no significant improvement in patients who had surgery, and that the results were pretty good. So most of these are treated with a closed reduction, splinting, and then early motion. On occasion, these patients have some reason to operate on them. If there's associated fractures, I'm going to talk specifically about that, and inability to obtain or maintain a reduction because of interposed soft tissue, or interarticular fragments. So those are some reasons why you would operate on a relatively simple elbow dislocation. This is a patient who had a non-concentric reduction. You can see that things obviously aren't good here. You would not accept this, and you would want to fix this. And this patient subsequently underwent a medial and lateral approach with fixation of the medial and lateral ligaments and early motion with good result. You can get there by going straight posteriorly and sliding around either side, or you can do separate medial and lateral approaches. But if you have a reduction that's not concentric, that's a relative reason to operate on that elbow dislocation. And that's maybe, for me, even in a busy referral practice, 1 patient in 10 or so. So most of the time, you don't need to do this. What about the fracture dislocation? So this is a whole different ballgame, as we know, and most of these patients are going to require some kind of operative intervention. This is a patient with a terrible triad type injury. You can see the radial head fragment stuck in the back, an elbow dislocation, and also looks like a coronoid fracture in the front. So I'm going to use the terrible triad as an example of fracture dislocations of the elbow to talk about what to do for them. And these are the surgical tactics that we've used in the past that boils down to the algorithm that we use to fix these injuries. And so you want to fix the coronoid, or at least possibly repair the anterior capsule if the coronoid fragment is too small. You want to fix or replace the radial head, and that should be a metallic modular prosthesis. On the lateral side, you want to repair the lateral collateral ligament and the common extensor origin. And often those 3 things alone are enough to make the elbow stable. If not, then you can talk about repairing the medial collateral ligament or putting on some kind of fixator. I'm not going to go into that too much because there's a couple of excellent talks about that later on in this session. But the first 3 are probably the most critically important to restoring stability in an elbow fracture dislocation. This is a cadaver model, and you're looking from the lateral side. The radial head has been excised, so you can see we've created a coronoid fracture here that's quite deep in the wound. But with the radial head out, which occurs perhaps 2/3 or 3/4 of the time with the terrible triad type injury, you can see the coronoid fracture pretty well. You can reduce it. This is a guide wire from a cannulated screw set. Reducing it and then fixing it with a screw is usually what we try and do in this kind of setting. This is an example of a reconstruction. So this wasn't an acute injury, but someone who lost their coronoid. We put a piece of iliac crest graft in there. You can see where the screw goes from the dorsal surface of the ulna into the graft in a countersunk and lag fashion to help fix that down, provide some stability for this particular elbow in a chronic reconstructive type case in conjunction with repair of the ligaments. So this is what it typically looks like. On occasion, these fragments are too small to fix with a screw, and then there's some debate as to whether lassoing them with a suture, and it can be placed the same way as you saw with an eyed K-wire, the same way you just saw the screw being placed, and then bringing that whole anterior capsule back down to the raw surface that it was ripped off from, and that may help improve some stability of the elbow. It's a bit controversial. There's some biomechanical studies that show it doesn't make much difference, but on occasion, I have found it to be very useful clinically. The radial head is the second most important bony structure there, and we know that it's going to be important buttress against posterior subluxation of the elbow. And in these situations, you want to fix or replace the radial head. In the setting of complex elbow instability, excision alone is not a good idea and can lead to rapid instability of the elbow. So you want to fix or replace the radial head, and these are the two options available to the surgeon here. If you have less than 3 fragments, in general, we try and fix those. If there's more than 3 fragments, in general, we try and replace it. That's roughly the guideline that some of Dr. Jupiter's and Dr. Ring's patients have told us. In my own practice in the literature, about 3/4 of patients with terrible tri-type injuries require a radial head replacement. Remember, if you are going to fix the radial head in the setting of elbow instability, you're putting a lot more force on that elbow or on that radial head reconstruction, and so the results are worse. If it's an isolated radial head fracture with a fairly stable elbow, there's not much force across your fixation, and you can get away with a fair bit. In the setting of elbow instability, the fixation is subjected to unforgiving force. And if you don't have good fixation, then what you can see here can rapidly happen. So that definitely plays a role in my decision-making as to whether to use a radial head replacement or whether to fix the fracture itself. Remember, when you're sizing these, always go down a size. The radial head's covered with cartilage. It's elliptical shaped. Make a long story short, one of the most common problems I see with radial head replacement is oversized or overstuffed. And so in general, I always go down a size when I'm picking my own radial head in this kind of setting. A lot of debate about radial head prosthetic options. I think everyone agrees they should be metal and they should be modular so we can independently modulate the size, the stem, and the width, etc. There's a smooth, loose fit, which is in general what I use, and the rough, tight fit that is also popular. Those work fine if they ingrow. If they don't ingrow, then you can get this really severe bone loss in the proximal radius. And a couple of designs have been removed from the market because of this complication that occurs in a small but set percentage of these tight fit radial head prostheses. On the lateral side, Dr. Driscoll and I showed that the pathoanatomy is usually a avulsion of the lateral collateral ligament off the distal humerus. There's often a bare spot there. And often you see the common extensor origin is torn off as well. So on the lateral side, you can expect this defect in the soft tissues. It usually comes off the lateral side, and you want to repair it back down there when you do your eventual exit from the joint after you've done the deep work. And that's a critical part of restoring stability to the elbow, is to repair the lateral side, the ligament, and or the CEO if that's come off as well. So back to our patient I showed initially. This patient had a closed reduction done in the ER, which was very successful and much better, but obviously not perfect. There's a large coronoid piece still there. The radial head is not concentrically reduced, and the elbow joint's gapping open somewhat. So we then went on to fix the radial head. We lassoed that coronoid piece down and fixed it with suture, and then repaired the lateral side. And this patient had a pretty good outcome from that. And that's a paper that Dave Pugh published back in 2004, looking at that standard surgical protocol. And remember, and this is just roughly what we did. Most of the time, we replaced the radial head, although occasionally we fixed it. Same thing with the coronoid, 50-50 between fixation and capsular repair. And we always fixed the lateral side. And those top 3 things usually made the elbow stable. Only 6 times out of 40 or so was it necessary to either go to the medial side or apply an external fixator. So those are often for revision cases or tough situations. The results were good, not normal. A mean flexion extension of arc of about 110 degrees, good form rotation, and mean elbow score of 89, which is dramatically better than what we've seen in the past, but certainly not a normal elbow. So to conclude, I'll say in most fracture dislocations, the elbow evaluates stability after a closed reduction, and most fracture dislocations require ORF. Most simple dislocations can be treated closed. A standard surgical protocol to repair these injured structures, including the coronoid, the radial head, and lateral collateral ligament, will usually make your elbow stable. Occasionally, you'll need to fix the medial side or put an X fix on, which I think we're going to hear about later in this session. Thank you very much for your attention.
Thank you, dear Michael, for your nice presentation. It was very useful for me and for sure for all the participants. Please maintain your connection until the discussion session. We want to have you there. Thank you. The next speaker will be my colleague, Dr. Seyyed Hadi Kalantar, orthopedic surgeon, assistant professor of Tehran University of Medical Science. The topic of his lecture will be hinged external fixator for unstable elbow joint. Dear Hadi, please start.
Thank you very much. Thank you very much, Dr. Bagheri, and thank you, Dr. McKee, for your nice presentation. I'm Dr. Kalantar. I'm an assistant professor of orthopedic and trauma surgery in Tehran University of Medical Sciences in Iran. Today, I'm profoundly honored to be a speaker among all these great surgeons and upper extremity surgeons, and to participate in the first POTA Biennial International Congress. My topic is about hinged external fixator for unstable elbow joint. Unstable elbow joint cannot be tolerated, and the earlier the intervention for unreduced elbow, the better the results. A stiff elbow joint, as we know, has better long-term results than an unstable and incongruent one. You have got to do something about this unstable and incongruent joint, as Dr. McKee nicely talked about in his session. If you have an incongruent and unconcentric joint, you have to do something about it. Do not accept incongruency. As you can see in this image, you have to do something. Even a reconstruction of even if the reconstruction of the ligaments do not work, you should do something about it and put the patient on an X-fix. If you do not do that, your patient will end up like this, and the joint will be destroyed very soon. There are some articles about using hinged elbow external fixator for elbow instability. Professor McKee and his colleagues has published their article in 1998 about management of recurrent complex instability of elbow with a hinge external fixator. They performed their study on 16 patients. They had few minor complications. They have 12 excellent results and 1 failure. They concluded that although technically demanding, the use of fixator is an important advance in the management of recurrent complex elbow instability after failure of conventional treatment. Dr. Jupiter and Dr. Rink has published an article in treatment of unreduced elbow dislocations with hinge elbow external fixation. They concluded the treatment of unreduced elbow dislocations with open reduction and hinge external fixation as much as 30 weeks after the injury can restore a stable, mobile joint without the need for tendon lengthening or transfer, ligament reconstruction, or even deepening of the trochlear notch of the ulna. Dr. Shahriar Kamrani and his colleagues has published their article about old unreduced elbow fracture and fracture dislocation. They studied on 12 patients with old elbow dislocation. They had 6 excellent results, 2 good results, and 4 complications. They concluded that use of hinge elbow external fixator will allow safe early range of motion while letting the bony and soft tissue reconstructions heal. There are not much articles about comparing hinge versus static external fixator of the elbow, but I found a recent article that was published in Journal of Orthopedic Trauma by Dr. Al-Qahtani. They said that static and dynamic external fixation are equally effective for unstable elbow fracture dislocations. But how can we apply the hinge elbow external fixator? You should, when you're going to construct your frame, you should pay attention about the bony anatomy of the distal humerus, and you should pay attention of the position of the ulnar nerve and the bony anatomy, and follow the principles of external fixation, of modular external fixation. Dr. McKee, in their article, has stated that the center of rotation of the elbow lies on an axis which is internally rotated between 3 and 8 degrees relative to the plane of the epicondyle, which means the lateral epicondyle is still slightly anterior to the medial epicondyle, and when you placing your central pin, you should put it slightly anterior to the lateral epicondyle, and when you take a lateral view of the CR and a concentric appearing capitellum and trochlea, and when for a unilateral hinge elbow fixator, you should advance your pin lateral to medial by paying attention to the ulnar nerve. You should pay attention to the perfect lateral X-ray or fluoroscopic view of your distal humerus. You should put your elbow in 90-degree of flexion, shoulder in exorotation. The elbow should see in the medial to lateral view, and then place your pin in the manner that I said. After that, you should have to follow the principle of modular external fixator placement. The central guide pin must not be bent when connecting the rods together. Dissect bluntly on the lateral side of the humerus to avoid iatrogenic radial nerve damage, and know the safe zone. 3 to 4 millimeter shank pins on each side are enough. Now I'm going through some cases about this elbow dislocation, unreduced elbow dislocations that were treated by hinge elbow fixators. The first case is an open elbow dislocation. You can see the simple elbow dislocation is not quite that simple. There's an open fracture of the ulnar shaft as well, and the patient arm was stuck in an industrial pressing machine, and there was many contamination of the wound and soft tissue defect. So there was nothing much to repair on the lateral side. The whole anterior capsule and lateral side ligaments were all lost, and there was a soft tissue defect that needed to be addressed by the plastic surgeon. So with this contamination, you cannot use allograft here. So what we did, we placed a hinge elbow external fixator, and this is the intraoperative range of motion, and the ulnar was fixed, ulnar shaft was fixed with a plate, and then the soft tissue defect was addressed with plastic surgeon. The lateral side and extensor supinator muscles, all that were left after the debridement, were sutured together, and the patient were treated by a abdominal flap, and a little bit of range of motion was allowed by the plastic surgeon. And this is the result after 8 months of follow-up. You can see a little bit of a heterotopic ossification and concentric elbow, and this is the range of motion of the elbow joint after 8 months of follow-up. The second case is the following cases that I borrowed from Dr. Kamrani, Dr. Shahryar Kamrani, one of the greatest hand surgeons in Iran. There are 2 cases here that I'm going to discuss. The first one is 19-year-old male who had a fracture dislocation of the elbow and was treated by a bone setter 3 months before his presence to the office. Dr. Kamrani managed him with a osteotomy of the olecranon osteotomy and extensile release of the elbow joint, and then putting him in a hinge external fixator and allowing the healing the reconstructed part of the elbow. And this is the 2 years follow-up of the patient with the range of motion. You can see the results after 2 years. The third case was a 30-year-old female with a simple elbow dislocation, came to the ER, and after close reduction because of the severe head trauma, she went to the ICU, and after that, they suspect the elbow dislocation, and the follow-up X-ray showed that the unreduced elbow and unstable incongruent elbow. And this is the range of motion intraoperatively before the operation. You can see the restricted range of motion of the elbow. And again, she went through olecranon osteotomy and extensile release and placement of hinge elbow fixator. Because of the humeral release, extensile release, they could manage to put the pin from medial to lateral and see it by the sight and vision. Didn't need to check it with fluoroscopy, but they checked it and that was perfectly center. It's important to put the pin in the center of rotation to allow the range of motion perfectly. And this is the follow-up of the patient after removal of the external fixator after several months. For the take-home message, I wanted to say that the elbow incongruence in stability should be avoided at all costs. External fixation should be considered whenever all our attempts to create a stable, congruent joint fails. You have got to respect the principle of external fixation and know the elbow anatomy, and the placement of the pin in the center of rotation of the elbow is the key to placement of the hinge elbow fixator correctly. Although there are reported some complications of the placement of hinge elbow external fixator and the use of it is more technically demanding, it's worth it using it when indicated. Thank you very much.
Thank you, Hadi, for your nice presentation. You have presented many nice cases that I think we could ask the panelists' opinion about these cases in the discussion session if the time let us. The next speaker will be Dr. David Bellona from Italy. Dr. Blonna is a renowned shoulder and elbow surgeon. He recently has been elected to the European Society of Shoulder and Elbow Surgery's Education Committee. Besides of more than 70 presentations and 40 publications, he is very active in any educational activities, such as making educational videos for M.D. I have heard about your technique that you called it elbow latarge, as I am one of the latarge lover. It was very interesting for me. We are waiting to listen to you, and the topic of Dr. Bellona lecture will be treatment of neglected elbow dislocation. Dr. Bellona.
Thank you very much for the kind invitation. It's really an honor to share my talk with you. I'm going to share my slides. Can you hear me?
Yes, it's very good.
So what to do in case of neglected elbow dislocation and chronic elbow dislocation. These are my disclosure, not really relevant for this topic, honestly. So how can we define chronic dislocation of the elbow? Chronic elbow dislocation has been defined by a good friend of mine, Marinelli from Bologna, as persistent and static dislocation where the elbow has been dislocated or subluxated for more than 2 to 3 weeks and can only be reduced surgically. So this is going to be the main focus of my talk. The problem with the chronic elbow dislocation is that the patient has severe stiffness, severe pain, plus instability. So usually the conservative treatment is not a good option for the majority of these patients. The problem in the treatment of this patient is that we have to face 2 conflicting goals. We need to restore elbow stability, and we need to regain a satisfactory arc of motion. And sometimes it's not easy to reach both our 2 aims. There are some case reports about the surgical technique that can be used to treat a chronic elbow dislocation. At the beginning, majority of the surgical technique were not anatomically technique. More recently, we have learned how to reconstruct ligaments. We have learned how to do a good radial head replacement and also how to replace the coroners in case we have a lack of bone on the corona that we have just learned. It's extremely important for the stability of our elbow. So I think that more recently we have learned how to be more anatomically trying to treat these difficult cases. For sure, and this is extremely important, the best treatment of a chronic elbow dislocation is the prevention. The problem is that we still don't have a clear idea which are the patients that will turn out to have a neglected elbow dislocation. So which are the main risk factors? We have tried to figure out in our population which were the main risk factor for a neglected elbow dislocation and a chronic elbow dislocation. And in our experience, the majority of the patients had a terrible trial. And the majority of the patients that had a terrible trial that then developed a chronic elbow dislocation, the majority of the patients were treated conservatively. So probably one of the main reasons is an underestimation of a terrible trial. This is a comparison between the patient that have been treated for a terrible trial and the patient that did not receive the right treatment for terrible trial in order to figure out the main risk factor. As you can see, the patient that developed a neglected elbow dislocation were in the majority of the cases female, older patient, and obese patient. So in my experience, probably obesity is the main factor for the developing of chronic elbow dislocation. But how can we treat them? It's not easy. There are no like magic number. I can tell you what is my experience. The first point that is extremely important is to do an extensive soft tissue relief and removal of HO. The majority of these patients have some kind of HO, even 2-3 weeks after the trauma. And then there are some elements that are important in trying to figure out which is the best treatment for our patient. The erosion of the trochlea is an important element. The time from dislocation to surgery. What about the radial head and the coronoid? And of course, there are other factors like general medical condition of the patients. We have tried to figure out a flow chart for the treatment of these complex cases. And as you can see, I think the first important point is the trochlea. If you have an erosion of the trochlea, and this can occur very early after the elbow dislocation, usually there is no chance for reconstruction. You have to put a total elbow or do an interposition arthroplasty. I will show you one of these cases. This is a 60-year-old female that had a coma, and then she developed ankylotic elbow. Since she was recovering very well from the coma, she underwent in another hospital release for the stiff elbow from a posterior skin incision. They did a medial and lateral release, but unfortunately, this is the patient 5 months after the release. And this is something that is not easy to be treated, and there are no perfect option for this patient. But as I told you, you can even think to reconstruct this elbow, but the problem is that, as you can see here in the CT scan, there is a lot of HO, but this is something that you can manage very, very easily during surgery. Also, the coronoid is fine. The problem here, you can see there is a huge erosion of the trochlea. So in my hands, this lady is a candidate for a total elbow replacement. And she was quite happy of the result at 3 months and at 1 year follow-up. Another case, this is a patient a little older than the first one. She had a fracture, dislocation of the elbow. She was reduced. As you can see here, there is a little piece of radial head that is missing. No information about the coronoid, but probably still there were some coronoid fracture here. But this lady did not have a CT scan at the beginning of immediately after surgery. She was placed in the cast, and this is the CT scan 3 weeks after the initial treatment. So according to our flow chart, We are still under 3 weeks from the trauma. There is some radial head that is missing. There is also coronoid fracture, but is not missing a huge piece of coronoid. So our option in this case, when we are under 2 to 3 weeks from a trauma, we try to treat this elbow as an highly unstable acute fracture dislocation. She had a radial head fracture, so we decided to replace it and then to repair the LCL and the MCL. Since the elbow was still unstable, we placed a hinge cast. This is the result, not a perfect result, but as you can see, this lady is doing quite well of the last follow-up. Of course, we cannot have an idea about the development of early osteoarthritis in the near future. This is another case, somehow similar for the type of injury, a coronoid fracture, a subluxated elbow that was treated with a cast, but 1 month after the initial treatment, the elbow is dislocated in the cast. So this is a very highly unstable elbow. At 6 weeks, when she was sent to us, we asked for a CT scan. As you can see, there are already some HO. Radial head is missing. The coronoid is comminuted, and you can see here that there are already some HOs that, as I told you, usually are developing very early after this kind of trauma. So what can we do in this patient? Usually after 1 month, we prefer not to repair, not to reconstruct MCL and LCL. We are very aggressive with the radial head replacement. And if the coronoid is missing, like in this case, we use a graft, what we have called elbow lateral J. We are using a piece of the radial head. See, this is a piece that otherwise we would put in the garbage, and we use this bone as an augmentation for the coronoid. Usually the elbow is stable enough, and so you don't have to use an external fixator. This is what we do. We do a box loop technique for the construction of LCL, MCL, radial head replacement, radial head graft for the coronoid, and then we use anchors to try to retensioning the extensor and flexor tendon loop. And this is the patient on 1 year of follow-up. This is the X-ray, and as you can see, there is a quite good new coronoid. This is the video that replicates the surgery in another very similar case.
Yes. David, do you hear me? I think your connection was lost. Okay. We will wait some seconds if David can reconnect to us. Yes, I think Dr. Bellona is completely disconnected. Then we should pass to the next lecture. Our next lecturer is Professor Lars Muller. Lars Peter Muller is from Germany. Dr. Muller is a professor of orthopedic surgery at the University Hospital of Cologne, and one of the main domain of his research and work interest is elbow surgery. He is also the head of the Department of Trauma and Hand and Elbow Surgery in his department. AO members know him good because of many AO events had him as a lecturer, and my familiarity with him was during one of these AO events. Welcome, Dr. Muller. We are waiting to listen to your lecture. The topic of Dr. Muller's lecture is reconstruction of old ligament injury in elbow. Dr. Muller, please start. Okay, Dr. Bellona, we missed your connection.
Okay, sorry for that. I don't know what happened. I can, if you want, I can resume very briefly my presentation. Can you hear me?
Yes, we hear you. Please complete
sorry
your
for that.
presentation.
I will just go very quickly through the surgical procedure. As I don't know where I had stopped my presentation. Again, this is a patient that had a chronic elbow dislocation that was treated 6 weeks from the trauma. As you can see here, the lady is stiff. As I told you, the most important part of this surgery is the extensive release of the soft tissue. You can do this extensive release both using an extensile posterior skin approach, but usually I prefer a double skin incision because I think that it's a little bit better for the soft tissue management. You have to release all the soft tissue, including the anterior and posterior capsule. Usually you don't have LCL and MCL, but you have some scar tissue around the medial and the lateral epicondyle. Once you have removed the remnant of the radial head, you go from lateral to medial, and to do exactly the same. You do an extensive release, and you have to prepare the bed of the graft. Since the elbow is very stable, what I've learned is just to try to put a big pin, trying to stabilize temporarily the elbow, because that will give you a much easier surgical field. And you simply use your graft as an augmentation for your missing coronoid. This part is not difficult, it's quite easy. And then what you do a box loop technique, trying to reconstruct both the medial and the lateral MCL. And normally we do these 2 tunnels very quickly using a simple ACL guide. And then you replace the radial head. Of course, it's important not to do an overstuffing. And then the last part of the procedure is the retention, the reconstruct of your 2 ligament. The majority of the surgery here is a soft tissue release, and the reconstruct is a quite straightforward procedure. What I've learned in this patient is that we have to be very careful about obese patient with a terrible triad, especially the patient where there is a mismatch between soft tissue and bone damage. These are the most dangerous one. So prevention is better than treatment. An early and aggressive surgery can improve function. So if you're able to do your surgery within 1 month, probably you will achieve much better result than after 1 month. A reconstruction with a graft can provide reliable, good results, but patients have to understand that these are salvage procedures. So thank you very much. Sorry for the problem with the connection.
Thank you, David, for your nice presentation and some interesting, complicated cases. Dr. Muller, we are here, we are waiting.
Nima, thank you very much. I sent in my lecture. I don't know whether you can get it going. Is that possible?
Yes, we have your lecture, but if you want to present it live, we could hear you, or we can replay your presentation that you have sent us. It's depending on you.
I can do it live. It's fine.
Okay. Oh, I think you start.
Okay, thank you very much for the invitation. And Nima, nice to see you again. And first of all, I would like to try to answer the question, what is an old injury? So the first case is 4 years after treatment of a tennis elbow with lots of cortisone injections. Unfortunately, in Germany, we still use a lot of cortisone in these cases. And the whole lateral condyle here, there is some synovial fluid around it, so no ligament really inserting there anymore. So I think that's definitely old. The second one is after a ligamentous elbow luxation, still a bony fragment there. And I think even though it's 1 year post-trauma with an instability problem now, here it's still possible to work without an allograft or an autograft, but a refixation, maybe some Krakow sutures, internal bracing is possible. And the third one is 3 months. And here on the medial epicondyle, still all the muscles and the ligament complex is inserting. And I think that's also a kind of young injury, although it's already 3 months. So I think the decision whether to use allograft, autograft or not, or whether to just use the biologic stuff that is still there and refix it, that's like an important decision when talking about old injuries. One study I have in my lecture, and this is from the Netherlands, Aidin, and these were really old. 50 patients, follow up 9 years after a posterolateral dislocation. And she found 21 cases where radiologically there were degenerative changes, and these correlated with medial instability. So I think it's quite surprising for me also. The posterolateral instability didn't correlate with developing arthrosis after 9 years after ligamentous elbow luxation. So, but I think the message is that we really should try to address medial instability very carefully. Interestingly enough, in this study, clinical results were not correlating with the development of the arthrosis. So it was just a radiologic finding here in this study. And concerning the basics, before I come to some cases, of course, most of the ligamentous lesions, as McKee just told us, can be treated conservatively. And this is a case actually where the whole medial ligament complex, of course, is acutely detached, no bony lesion here. And after 4 months, actually no operation or anything, we can see in their MRI scan that we did here that the medial ligament, at least partly, is back there again, and also a big scar. And I think as we have just learned, we don't have to operate a lot of these ligamentous lesions, ligamentous elbow luxations. Concerning the external fixators, we don't like them. We try to not to use them anymore, but in the heavy patients, I think there the external fixators still play a big role. Otherwise, we try to fix the problem without using an external fixator. And I will come to the cases in a second. We also don't use dynamic fixators anymore, actually, because we had problems with the dynamic ones quite a lot of times. So we use static ones again. And for physiotherapy, we take off the longitudinal bar. Overhead motion protocol plays a big role to get good movement. So here it was a chronic dislocation in an older lady. And we did all the ligament work from the medial here and the lateral side, some internal bracing. But in the older persons, I think with ligamentous chronic lesions, quite often you don't have a lot of material. So we did some internal bracing on top and then put an external fixator on. And we always do a video for the physio to take off the longitudinal bar and then do the overhead motion protocol. Concerning allografts or autografts, the Baten score preoperatively is important. And if it's above 5, autografts, of course, don't work. The question, of course, then always is if there really is there an indication? Is it really a relevant instability on one side? But if you have an indication in these patients for ligament reconstruction and all injuries, autografts will not work, so you will have to use allografts then, I think. And post-operative, these overhead motion protocols really play a role. We always use the handy of the patient. We do a small video with the handy of the patient, and the patient then shows the video of this overhead motion protocols to the physio, usually prosupination and 90 degrees of flexion. And then due to gravity, we have a good flexion control here, and some goes to the nose and the ear. And that's, I think, really important in the postoperative care. So now 3 quick cases, one from the lateral side. This was a cortisone case. This lady with a so-called tennis elbow got lots of injections, and obviously no ligament really inserting there on the lateral side anymore. She had a massive posterolateral instability. We do an arthroscopy here to look for additional lesions. I think you don't really need to do an arthroscopy, but in our clinic, it's a standard. We look for a plica for lesions of the cartilage and determine the amount of instability. And here it's a 3rd grade of instability with the conoid process really going nearly behind the trochlea. So I think that's an indication for a ligament reconstruction here. And it's quite common actually in Germany and Denmark. Bo Olsen described this first time some years ago. We use the medial triceps slip. It's a half centimeter wide triceps part from the medial side of the triceps. It's very thick there. And we use it for the medial and for the lateral side in a hybrid technique. We use an endo button on the ulnar side because we have good cortical bone here, and usually a swivel lock on the humeral side to fix our transplant. Second case is a tennis player, medial epicondylitis. He had some cortisone and he already had pain since 16 months on the medial side. And when doing a serve, not a service, a serve, he heard a click. So that was a definite rupture of the ligament. The McKee maneuver was positive, and in the MRI also again on the medial side, the ligament being detached from the humeral area. And so here in the MRI, we can see the typical pathology of these isolated medial instabilities, with quite often some osteophytes around the fossa olecrani at the proximal ulna because of the ligament being insufficient. And on the long term, also a radial arthrosis can develop due to a medial chronic instability with a kind of old ligament lesion on the medial side. And also we don't do double bundle, we do single bundle here on the medial side. I know that can be discussed, and all the baseball players in the States, they get double bundle in most cases, but the single bundle literature results are the same. And again, we use a hybrid technique with an endo button in the ulna and a swivel lock, a resolvable swivel lock here on the humeral side. Finally, a global instability of this lady. She's young, but she's heavy. She had 4 ORs, lots of anchors, not successful, obviously, and she already has arthrotic changes, of course. And that's always the question, should we do a prosthesis? But she's 43 and 120 kgs. I think it's not a good candidate for a total. So massive global instability here in this case. And we did a box loop technique, as just described by David, also using a semitendinosus allograft. Of course, you can also do 2 ligament reconstructions on both sides without going all the way through the bone, but just do a normal medial. And in this case, I think you need a lateral reconstruction in order to address this global instability and postoperative really these overhead motion protocols, they make especially flexion. You get a lot of better flexion when you do these protocols, and I think they're really worthwhile. Finally, a case, 74. She had 7 ORs, unfortunately, still a deficit, obviously bony of the coronoid, luxation. Of course, the ligaments are gone here. And I think these cases, when the patients are above 70 with multiple operations beforehand, a linked prosthesis really is a nice procedure. Nima and everybody, thank you very much for your attention.
Thank you, Lars, for your nice presentation. Since today, I think all of us will be afraid of a simple tennis elbow because of your case. Okay, we are in the discussion session. I would like to ask all the panelists to activate their videos. We have about 10 minutes to answer to the audience's questions and the comments of all the panelists about the lecture. Hadi, I think you have a question. May you please ask your question and we will hear from the panelists.
Thank you very much. Okay. Thank you very much from all the speakers. I want to ask Dr. McKee, is there any critical size for chronoid process that you will choose fixation or using the tunnel for the passing the or using anchor sutures or using plates or or you use just the classification of the Murray for fixation of the chronoid?
That's a good question. So number one is that the coronoid piece is usually bigger than what you see on the x-ray. So I think George Athwal and Graham King wrote a paper about this. It's got a large cartilaginous cap on top, so that the piece itself physically is often bigger than what you expect to see in the x-ray, and you can use that to augment your fixation, number one. Number two is that essentially if it's big enough to take a screw, and by that I mean I use a 3.5 or 4.0 cannulated screw, I will try and do that first as my primary treatment. And that's the number one goal if I can make it happen. If that doesn't work, then I will describe there. So it's bigger than you think it's going to be. Try and get at least one screw into it if you can. And if that doesn't work, then I do a lasso suture and bring it down through the same hole that I just put the screw up through. And you can use an eyed K-wire and put or a K-wire passer or a suture passer and bring it back down out through 2 holes in the ulna. So that's roughly what I do.
Thank you, Professor McKee. The next question is from Dr. Tawakkoli, the chair of POTA. Dr. Tawakkoli.
Okay, I have a question from Professor McKee. Is he available or no? McKee.
Yes. Hi.
Okay. Hi, Professor. What is the role of the annular ligament in the elbow dislocation? Is there any role of this ligament or no?
So it's a good question. If you look at our series, out of 40 patients, 6 times we went over to the medial collateral side. So the medial collateral ligament we fixed 6 times out of 40, usually because we were there for another reason, to look at the ulnar nerve, or there's a flap of tissue stuck in the joint. So if you fix the coronoid and you fix the radial head and you fix the lateral collateral ligament, then usually you don't need to worry about the medial collateral ligament in most patients. That will heal on its own, as it does in an elbow dislocation. If you have to open an elbow and you have to be in the medial side for the nerve or something, the flap of tissue is caught in there, and I've seen that before, that's usually an indication to go on the medial side. If you do those things and the elbow is not stable, fixing the medial collateral ligament alone often is not enough to make it stable enough. It's not a very satisfying repair. And so usually in that situation, we're going to a hinged external fixator or something of that nature in that setting.
Thank you very much.
Okay. Next question, Dr. Kalantar, please ask.
Thank you very much. Sorry. I have a question from Professor Muller. I wanted to ask him two questions, actually. Do you always perform MRI after simple elbow dislocations? When do you use them? And whether you suspect something, you use them? Because in knee dislocation, the story is different, and we will perform it electively for the patients. And does it change your plan for the patient? The second question is, what is your physiotherapy protocol when you use the static external fixator? Aren't you afraid of redislocation of the elbow joint? When do you start the elbow motion? Thank you very much.
Yeah, concerning the MRI, of course, it's some kind of, it's luxurious. So when we have ligamentous elbow luxation without any bony pathology, we try to see the patient after 1 week, and then we look for how they move and if they have massive hematoma or not. If they have massive hematoma, especially on the medial side, and have bad extension, I mean an extension deficit of more than 40 degrees after 1 week, that makes me suspicious. And in a young patient, young sportive patient, we are very generous with doing an MRI to really look for especially muscle lesions. And it's like in shoulder luxations, nobody discusses anymore about doing an MRI. And I think if you have the possibility of doing one in young sportive patients, yes, we do it. But I think it's a good, for us, a good hint to do it after 1 week if we still have bad range of motion and massive swelling, especially on the medial side. And the decision then that comes out of the MRI, I have to admit, quite often you see massive lesions in the MRI, but you don't need an operation. So it's difficult. And in some of these patients, if they don't want an operation, even if they have a detachment of the muscles, we agree to keep on conservative treatment if radiologically they are congruent in the joint. But remember the Adolfsson study from Sweden? He looked at his patients that went into chronic instabilities after simple or ligamentous elbow luxations. And he revised, I think it was 8 patients. They had to revise after treating them just with a cast for 1 week and then letting them move. It was not a lot of percentage of their whole luxations, but 8 patients. And all of these had massive muscle lesions. Even the triceps was in some cases ruptured, and especially lesions of the pronator flexor mass on the medial side play a role. So I think, I know it's not a perfect answer to the question, and we don't know which patient really is a good one for an MRI, but we have the possibility to do it here quickly, and we do it in young sportive patients. Otherwise, 1 week, if it's not in a good situation. And then the second one, I hope,
Dr. Muller,
Dr.
May I interrupt for 1 second? So you would agree that the treatment of the simple elbow dislocation in your practice is guided more by the clinical exam and how the patients do a plain X-ray rather than the MRI. You agree?
Yes.
The MRI shows some scary things, but doesn't always mean you need an operation. Is that, you agree?
I agree, but in a young sportive patient, sometimes you have a big fragment, chondral fragment also being behind the capitulum out there, which you could not see with a CT or with a normal X-ray. So it plays a role in these patients. Maybe these fragments get resorbed, but if I have a young patient where I detect this osteochondral, it's a Faber lesion kind of fragment behind and then I see detachment of the muscles. I have massive swelling and I have an extension deficit of 50 degrees after 1 week, and it's a sportive patient. And I see that it's usually on the humeral side, as your study nicely showed, these pictures from 2003 or something. I always have them in my lecture. So, and then I advise them to do an operation. I don't press them to do one, but I tell them I think it will get a better result because what we try is to avoid chronic instabilities, of course, and in the sportive patient, I think it plays a role.
What percent of simple elbow dislocations do you operate on in your practice?
No, well, I think it's 5%, 5 to 10%. Okay. Not more.
10%.
We have a 10%. Sports university here, so we have a lot of sportive people.
Tennis players. Looks like tennis players.
Yeah. Unfortunately, not me sportive anymore. I wish. David, you agree?
I think we all agree.
Yes, absolutely. My rate of surgical treatment is a little bit higher. It's about 10%, but more or less the same principle. I try to examine the patient after 1 week. The problem is not easy to examine the patient after 1 week because usually they are a lot of pain. I mean, most of them, they are pain and they are very apprehensive. So it's not easy to test the MCL and the LCL. What I've learned from some of the patients that it's extremely important after 1 week to examine the triceps, because some of my young patients with an elbow dislocation have a complete lesion of the triceps. So I think that usually I test them with extension with gravity, and you can have a bad experience with that. So I recommend you to remember to try always the strength of the triceps after a simple dislocation of the elbow.
Good point.
Concerning Seyyed, concerning the second question concerning the external fixators, I just think flexion plays a big role, and I'm not afraid of relaxation really if I let them do massive flexion. Okay, let them go into flexion and accept the extension deficit. So then you don't have such a high risk of redislocation, I think.
Thank you, all the panelists, Professor McKee, Professor Muller, Professor Blonna, and Professor Kelantar. I think, unfortunately, we don't have any time to have any additional questions. If any of the panelists have any comments, we can hear them, but if not, we could pass to the next session.
Thank you very much. Great session, Dr.
Very much. Bye-bye.
Everybody.
Hope a nice Congress.
Thank you. Thank you very much. Okay. The next session is consisting of 4 lectures and a discussion session, the same as the first session. Our first lecturer in the second session is Professor Hauseman. Professor Hauseman is the Robert K. Lipman Professor of Orthopedic Surgery, the Vice Chairman of the Department of Orthopedics at Mount Sinai, and Chief of Hand and Upper Extremity Surgery for the Mount Sinai Health System. Dr. Hauseman is an internationally recognized, renowned upper extremity surgeon who treats disorders of the hand, elbow, shoulder, and peripheral nerves. Castle Connolly and New York Magazine have recognized him as one of the nation's and city's top doctors. It's our honor to have you, Dr. Hauseman. Please start your lecture under the title of Montegial-like lesions in the proximal forearm fracture dislocation.
Thank you so much. Congratulations on your Congress. And I truly appreciate the opportunity to participate. That was an excellent first session. I'm going to continue to elaborate on the theme that we've heard from the previous speakers, which is the problem of instability, and particularly medial instability due to medial collateral ligament injury of the transverse and posterior band. Specifically, the injury that we'll focus on is the Montegia fracture dislocation. This is just a picture of my institution in Central Park, right in the middle of New York City. And I hope you all will someday have an opportunity to come visit us. So Monteggia variants include radial head fractures, coronoid fractures, and ulnohumeral instability. And there's a spectrum of different injuries. This is the Rosetta Stone. That's an artifact that was critical in helping people understand early languages, Greek, Demotic Greek, Aramaic, and I like to think of the X-ray as the Rosetta Stone for the elbow. So when you look at an X-ray, don't concentrate on what bone is broken. Look at the fracture pattern and use that to predict what the soft tissue injury will be. And just take inventory, the lateral collateral ligament, the medial collateral ligament, the anterior capsule. So use your X-ray not only to understand the fracture, but it can also give you very important information about the associated soft tissue injury, which is very important. Specifically with Monteggia fracture dislocations, the structures that are most frequently injured, the soft tissue structures, are the lateral ulnar collateral ligament, the proximal portion of the interosseous membrane. The medial collateral ligament is typically not injured in most Monteggia fractures. The most widely used classification is the Vado classification, and this refers to the direction of dislocation of the radiocapitellar joint and whether or not there is an associated radius fracture. This was elaborated by Jussi Jupiter, who subcategorized these injuries in order to reflect whether or not there was an injury to the coronoid that would affect instability. So here is a typical injury. X-ray is usually sufficient to make this diagnosis. I don't always think a CAT scan is necessary. What the CAT scan will help you with is understanding the coronoid fracture in these injuries. So treatment involves an anatomic open reduction internal fixation, repair of the lateral ligament complex, and then treatment of the radial head, either by open reduction internal fixation or arthroplasty. And then you have to deal with the coronoid. You can do this through either one or two incisions. It is thought that making a separate lateral incision for the ligament repair or the radial head treatment may reduce the incidence of heterotopic ossification, and we prefer a more anterior approach through the Kaplan interval. For radial head fixation, I am not a big fan of plates. Plates are good in some areas in the body, but I think that this type of intermedullary so-called tripod fixation through the dense subchondral bone of the articular surface is really a more reliable way to fix the radial head. And if it's just not fixable, as we've heard from Dr. McKee and others, proceed to a radial head arthroplasty. And I would certainly agree with downsizing one size because overstuffed radial heads are a common problem. So an accurate reduction is critical, and you want to either use a pre-contoured plate or you want to pre-bend the plate, and then consider where the plate should be applied. So if it's applied posteriorly, that's the usual practice. And usually the plate is strong enough, but in a large individual, you may be better off applying the plate to the medial or lateral surface so that you get the extra thickness of the width of the plate to resist bending in the axis of rotation. Also, if the plate is placed medially or laterally, you can get bicortical fixation in the proximal fragment. One sort of trick that I use is to determine what direction the instability is in. So if the radial head has dislocated anteriorly, I will actually put a very slight bend in the plate with the apex posteriorly to help resist those forces that are trying to redislocate the radial head. The next step, of course, is reducing and fixing the coronoid fragment. That's critical. And then I always use autogenous bone graft for the ulna fracture in every case. So if we go back to our index case, here I have elected to use medial and lateral plates because of the degree of comminution in this area. And I didn't feel that one single posterior plate would be sufficient. And this is a radial head that's quite comminuted, and I treat that with arthroplasty and then the additional bone graft. Here's an example showing the posterior dislocation. The radial head will have a tendency to try to sublux posteriorly. So I have exaggerated this, of course. I wouldn't put that much of a bend, but I will put a slight, ever so slight, maybe 3 degrees or so of bend in the ulna plate in order to counteract the tendency for subluxation or dislocation. And then the final step is if the ulnohumeral joint is still unstable, then you will need supplemental stabilization. And that can be the external fixator that we heard, or an internal joint stabilizer. So here is typical case, unstable, dislocated, lots of comminution. And I cannot trust my coronoid fixation. I know that this is so comminuted that I can never make this strong enough to resist the forces. So this is going to require some sort of supplemental stabilization. So I begin with my coronoid repair, and then deal with the radial head, apply my ulnar plate, and everything looks like it is reduced, but it's not really stable. So we go ahead and finish the repair. Try to incorporate the coronoid fragment. But again, as I said, this is sufficiently comminuted that I really don't trust that coronoid. Always, as I said, bone graft, we take that with a little percutaneous device and just spread it along the fracture site. But how to make sure that this remains stable? So I agree with the concept of an external fixator. It has just proven in practice to be very, very difficult to get that axis exactly correct. And so the contribution of Dr. George Orbe was to shrink the external fixator and make it an internal external fixator with an axis pin and a plate that affixes to the ulna. And this basically reassociates the ulna with the distal humerus. And so the device is then applied. Again, it's really an external fixator that has just been scaled and shrunken so that it can fit inside the joint. And this is a very stable construct that allows us to move and will keep the joint reduced. And so here's what that looks like clinically. This is the internal joint stabilizer, and this is just stacked on top of our posterior ulnar plate. And these are X-rays showing the appearance. And again, what this does is functions as an external fixator in the same manner, keeping the radiocapitellar and the ulnohumeral rotation reduced. And one final picture of that construct that I think allows you to appreciate how essentially creating a metal ligament from the distal humerus to the ulna will help support that articulation. The surgical approach that we use for the coronoid is a modified Taylor-Schaum approach medially. And again, invest whatever effort you need to into trying to reconstruct that coronoid. And as I said, iliac crest graft, just a little bit is all you need for the ulna fracture. Problems, there is a propensity for non-union of the ulnar fractures reported in literature. I think that can be minimized by good fixation, again, using, if necessary, 90-90 or 180-degree plate constructs, using iliac crest bone graft. I emphasize that over and over again. And then if I have any concern about stability, either of the fracture or the joint, I will not push the rehabilitation. And I would suggest prioritizing healing in a reduced anatomic position over range of motion. You know, I tell my trainees that you should choose your complications carefully. And we have a good treatment for a stiff, stable elbow. Contracture release has been proven to be reliable and reproducible, but we do not have a good treatment for a stiff, unstable, or subluxed elbow, as we saw from the first lecturers. And so, if necessary, slow the rehabilitation, Don't worry about the motion. You can achieve that later on with a contracture release if necessary, but the joint has to heal in a stable, reduced position. So, Mamnoon, thank you very much. It's really an honor to be with you today.
Thank you very much, Dr. Hauseman. I know you are on your working day, you are in the operating room. Thank you for your valuable time. That was very interesting. Please be with us until the discussion session. Okay, the next lecturer is my dear colleague, Dr. Leyla Zanjani. Leyla is a faculty member of Tehran University of Medical Sciences and is a well-known shoulder and hand surgeon in Iran. The title of her lecture is Distal Biceps Tendon Repair Treatment Alternatives. Thank you, Leyla, for accepting our invitation, and we are waiting to hear from you.
Okay, hi everybody. Thank you, Dr. Bagheri, for your introduction of me. I'm going to talk about distal biceps tendon tears with a special focus on its treatment strategies. As a brief introduction, distal biceps tendon tears are not very common injuries, but its incidence is increasing, especially in recent years. It seems to be increasing almost in young active population. It's mainly affect young to middle-aged men around 40 to 60 years of age. And the standard mechanism of injury is applying an eccentric force on a flexed and supinated elbow. There are some predisposing factors to this injury, including degenerative changes in the tendon or some anatomic factors like presence of bone spores in around bicipital tuberosity, also high BMI, history of smoking, and also using anabolic steroids are some of the predisposing factors to these kinds of injuries. Biceps tendon has two distinct heads, and the distal biceps tendon also inserts separately because of the 90 degrees of external rotation in the muscle between its origin and its insertion. Short head of the tendon inserts distally to the long head in the bicipital tuberosity. So the long head mostly creates supination moments, and short head creates mostly a flexion moment in elbow motion. And to classify these injuries, we use the classic classification as partial or complete tendon tears. Each one can be insertional or intrasubstance tears. Also, when there is a delay between the injury and the diagnosis or treatment, more than 4 weeks, we call it chronic injuries because the treatment strategies are different in these patients. And the diagnosis is mostly clinical, according to patient history and physical examination. But we can use paraclinical means like MRI in more complex patients, especially for partial ruptures, to estimate the percent of the injury of the tendon. So we have two kinds of treatments. As usual, we can approach to the patient non-operatively or operatively. According to the literatures, non-operative treatment of acute distal biceps tendon tear can result in around 40% loss of supination strength and even more loss in supination endurance. Also, there will be around 20% loss of flexion strength and Most of the patients report subjective loss of function according to functional scores like DASH scores or Mayo elbow score. So we can say that using non-operative means in a young, active, high-demand patient may make some problems with their daily living activities requiring forceful supination, like using a screwdriver. And we may consider non-operative treatment in low-demand and older patients. Operative treatments is associated with excellent results, functional results, but it's also associated with some adverse events like any other operative treatment. The most reported complications are including transient sensory loss, mostly in lateral antebrachial cutaneous nerve, and less than that in superficial radial nerve. It's around 10% in patients, but it's mostly transient, not permanent. Also, there are reports of transient motor loss, mostly in posterior interosseous nerve, and after that in median or AIN nerves. Also, there are reports about heterotopic ossification incidence, which can be affect the patients around 10% in X-rays. But we have to say that clinical loss of forearm rotation is much less than that. It's around 0.5% in patients. So it's not very significantly clinically important for us. And overall, we can say that surgical refixation of the detached tendon attachment can be considered safe according to low rates of surgical complication, and it's preferred over non-operative treatment because of the better functional results. And so when we want to choose the surgical treatment, we have to consider some important points, including the fixation point, our surgical approach, the use fixation technique, and the using, and if we want to use augmentation or not. I will discuss each one in details. First of all, the fixation point. We could prepare the tendon either anatomically at bicipital tuberosity or non-anatomically, which means to tenodez the biceps tendon to the brachialis tendon. It's obvious that anatomic repair is preferred over non-anatomic repair. The non-anatomic technique has been reported in some chronic, highly retracted tendon when there is also injury in laceratus fibrosus structure. But the clinical results is not very good and suboptimal, so we prefer anatomic repair when it's possible. About the surgical approach, we will have two options. Either single incision approach, which was introduced by Dobby, or double incision approach, which was introduced by Boyd around 20 years later. Each approach has its own proponents, but we have to say that there is no significant difference in their outcome, either clinically, in strength, or in functional scores. There are some reports of lower pronation lower pronation of forearm in the double incision approach, which may be because of the dissection of supinator muscle and creation of some fibrosis in this muscle, but the degree is not very significant and it's not of clinical importance. And also there are some historic adverse events. We call it historic because they're becoming less and less. For example, single incision approach is considered to be associated with more nerve injuries, but by introducing new methods of fixation like anchor suture or interference screws, these complications are less today. Also, double incision is considered to be associated with more heterotopic ossification risk, but the alternations in this approach, for example, introducing the muscle splitting approach, lowered the incidence of heterotopic ossification. So overall, these two approaches are not very different in terms of results, and each surgeon can wisely choose between one of these approaches. About the fixation technique and choosing the best preferred fixation, there are three kinds of techniques. We can either use transossal sutures, we could use a suture anchor or interference screws, and we could use also cortical button. Each technique has its technical consideration, but overall, literature shows that cortical buttons have superior pull-out strength over the two other kinds of fixation, but because in daily living activities, human elbows maximal eccentric force is below the failure cutoff for all fixation devices, we can not see any clinical difference between these three means of fixation. And lastly, about using augmentation. This is mainly used in chronic retracted cases or when the quality of the tendon is not good for direct repair. There are three main means. First of all, we can use lacertus fibrosus. If this structure is still intact, we can use it to augment our tendon biceps by tubularizing it around the biceps. It can augment its strength and also its length, and we can repair it directly to the bone. We also can use autograft tendons or allograft tendons. The most used autograft is fascial lata, and after that semitendinosus. Allograft alternatives includes Achilles tendon or semitendinous tendon. The point is, although the direct repair of the tendon reports better functional results, but when the direct repair is not possible, all of these reconstruction techniques had excellent functional outcome scores in literatures. So we can recommend that in a young active patient, in a high demand patient, when the primary repair is not possible, to avoid the functional problem, we can use any kind of reconstruction to repair the biceps tendon. And also it's recommended to avoid autograft reconstruction because the results of autograft and allograft are mainly similar, and we can avoid autograft unnecessary donor site morbidity. And finally, there are still controversies regarding the treatment strategies in distal biceps tendon repair. Also, there are new trends, especially in in fixation methods. You can see, for example, intramedullary cortical buttons as an alternative to endo buttons. And also, there are some new surgical approaches, especially endoscopic approaches as minimal means to approach partial tendon tears. But according to the excellent results of any surgical repair techniques, we can overall say that surgical repair or surgical reconstruction is recommended to any high demand active patients with chronic or acute distal biceps tendon tear. Thank you for your attention.
Okay, thank you, Leyla, for your nice presentation. I would like to invite my dear colleague, Dr. Aidin Arabzade, a faculty member of Tehran University of Medical Science and one of the most famous hand surgeons in Tehran. Our topics are a little diverse as the elbow joints receive less attention than other parts. We were obliged to cover most important topics around the elbow joints. The title of the Dr. Arabzade lecture is How to Deal with Post-Traumatic Radioulnar Synostosis. I invite Aidin to start his lecture for 10 minutes on this topic.
Thank you very much, dear Nima, my dear friend. It's my pleasure to be in this session. Hello, all colleagues. I'm Aidin Arabzade, an orthopedic hand surgeon from Tehran University of Medical Sciences. And the topic I'm going to present is how to deal with post-traumatic radioulnar synostosis. Post-traumatic radioulnar synostosis after fracture of elbow and forearm is a relatively rare complication. It is defined as osseous or fibrous fusion of two bones of forearm that leads to loss of rotational movements of forearm, including supination and pronation, and serious functional impairment in everyday life. It can occur after both non-surgical and surgical treatment, and its incidence varies from series to series at 0 to 9.4% of patients after ORIF. There are several risk factors fall into two groups, trauma-related and treatment-related. Trauma-related risk factors are Monteggia fracture, fracture of both forearm bones at the same level, open fracture, significant soft tissue lesion, comminutive fracture, high energy kinetic fracture, associated cranial trauma, and bone fragments on the interosseous membrane. Overall, any high energy trauma that cause interosseous membrane and soft tissue injury may lead to radioulnar synostosis. And treatment-related risk factors are excessive trauma to surgery interval, single approach for ORIF, too long cortical screws that beyond the second cortex, primary bone graft, and prolonged immobilization or delayed rehabilitation. The diagnosis is found on pronosupination blockage some months after forearm fracture. Both active and passive movements are limited. In complete radioulnar synostosis, the patient is pain-free with complete blockage of rotational movements, but in incomplete synostosis, limitation of movements are accompanied by pain. Radioulnar synostosis can take place overall throughout the forearm. Vince and Miller classified it to three types. In type 1, distal radioulnar joints are involved. In type 2, diaphysial non-articular middle and distal thirds are involved. And in type 3, proximal third of radius and ulna are involved. Jupiter and Ring laterally modified this classification. They subclassify proximal third into three different types. Type 3A at the level of the bicipital tuberosity, type 3B in the radial head, and type 3C is a continuation of heterotopic ossification from the distal humerus and elbow. And what about management? If a rotational movement is functionally unacceptable, surgical management is the gold standard to improve forearm rotation and function. The patient's cooperation and compliance with the post-operative therapy is very important issues. We should keep in mind that the possibility of recurrence should be explained clearly to patient before doing any surgery. But do we have to do surgery for all patients? No, we can do conservative management in these situations. Patients with a functional arc of motion, low demand patients with high comorbidities, and patients unable to accept the risk of surgery. This figure shows the summary of Hastings and Graham guide to surgical treatment. Darach and Sow-Kapanji procedures can be done for type 1. Ectopic bone resection with or without interposition can be done for type 2 and 3A. Radial head resection or replacement can be done for type 3B, and total elbow arthroplasty should be considered in type 3C. But the question is this: does the excision of ectopic bone solve all problems? Several important issues are controversial. The first, surgical timing. There is no consensus on optimal timing of surgery. We can use radiographs, bone scans, and alkaline phosphatase levels serially to evaluate bone maturity, but none of them have been definitely proven. We should operate patients neither too early with risk of recurrence, nor too late with risk of soft tissue contractures. In general, the consensus is between 6 months and 2 years. The second, resection with or without interposition. The use of an interposition material, either biologic or synthetic, continues to be controversial. There are several choices. Synthetic material like silicone, polyethylene, bone wax, allografts like fascia and muscles, and vascularized and non-vascularized autogenous material like facial and adipofacial flaps. Although I have a small amount of patients, in my practice I use non-vascularized free flaps, but I'm not sure if it has a positive effect. The third, adjuvant therapy. Although NSAIDs, low-dose radiation, and maybe bisphosphonates in several studies have been effective in preventing heterotropic ossification in the hip, but it is still unknown in preventing recurrence in radial ulnar synostosis. Routine use of radiation or indomethacin is still not recommended unless for high-risk patients, like patients with head trauma and severe soft tissue injury. In my practice, I use indomethacin 20 milligram TDS for elbow fracture and for prevention of radial ulnar synostosis. And finally, about rehabilitation. There is no doubt that early and intensive rehabilitation should begin as soon as possible after surgery. As I said before, the patient's cooperation is a very, very important issue. We can also use bracing as an assistive therapy. Splinting, serial splinting in extreme supination and pronation is often used to prevent the recurrence of radial ulnar synostosis. Thank you very much, dear Nima.
Thank you, Aidin, for your nice and good presentation. I would like to, okay. Hello, Amir. Dr. Amir Reza Farhood is a faculty member of Tehran University of medical sciences and know and a renowned hand surgeon, international hand surgeon now. Dear Amir, we are really miss you.
Me too.
Amir is now with us from Canada. We are waiting to hear your nice presentation under the topic of management of forearm non-union.
Okay, hello everyone. Thank you, Nima, for inviting me for this lecture. And thank you for all of the speakers for very nice talks about different topics. Actually, my lecture is about management of forearm non-union. I think by the introduction of new devices and new techniques from the last century, we are facing less cases of forearm non-union. But when we face a case of forearm non-union, actually it's a challenge for both patients and surgeons, because it destroys the function of patients significantly, and on the other side, the surgeon actually is full of fear to deal with such complication. Today, we know that forearm functions as a three articular joints. Actually, we have PRUJ, DRUJ, and now the concept is that interosseous membrane is working like a joint. So treating forearm shaft fractures should be like treating all of intra-articular fractures, anatomic reduction, rigid fixation, and early movement are principles of treating an intra-articular fracture. The rate of forearm non-union by plating and ORIF is 5% in recent studies. But the condition of injury is very important, because comminution, high energy trauma, open fracture, and more importantly, technical errors are factors that can contribute to non-union. The difficulty for a surgeon is restoration of the length and bowing of radius and exact anatomy of the forearm. So it's difficult to guarantee the outcome of a forearm non-union. Usually we have shortening, positive ulnar variance, and these things makes our outcome different. The first, I will do a review of articles in last two decades. The first article is about treating forearm non-unions by Ring and his colleagues, about 35 cases. I want to show that how we are confused by controversy about the type of treatment, the type of grafts, being single stage or two-stage techniques. But I think at first we should make it clear that our non-union is infected or not, and how much is the defect. Brink treated his patients with bone graft, cancellous bone graft, and reorif with plates. 10 patients of 35 had deep infection, had history of deep infection, and it's interesting that all of them healed, but 12 cases had poor or unsatisfactory outcomes, functional outcomes. These authors believe that up to 6 centimeters of defect can be treated with cancellous bone graft, reorif and cancellous bone graft. For atrophic non-union, we have to use grafts, but for hypertrophic non-union, we can only use more rigid fixation. They recommend that some studies show that three-cortical graft instead of cancellous graft can work. But when we have infection or larger than 6 centimeters of defect, we should use free flap or vascularized flap, because creeping substitution cannot result in union. My review is about different studies. Two first studies shows that how three cortical bone graft and replating can work. Some studies have some infected non-unions, and some of them are only non-infected non-unions. These two studies show that when we use block, graft block, in infected non-union, it cannot work always. But for non-union that is aseptic, it can work. So an option is three cortical graft. In this study, they have the result of two infection in their patients and two non-unions. The technique is simple, I think, but because we can realign the bones and restore the length, and the results for non-infected non-union is interesting. Another study by David shows that we can use three cortical bone graft and intramedullary nailing instead of plate. In 10 cases that I think 2 of them had infection, they used this technique. And finally, about 6% of non-union they achieved. So I think 6% for is not a low rate. For infected non-union, 2 studies showed that 2-stage techniques of debridement using cement and external fixator or only debridement, and after that using 3 cortical iliac crest bone graft can work well, and their functional outcome and also their union was acceptable for infected non-union. In one study, they didn't use external fixator, but in one study they used cement for more than 3 centimeters defect and also external fixator, and after 6 weeks of antibiotic therapy they used 3 cortical graft in plus strut graft. Another technique that is very popular these days is about induced membrane technique, that for 12 patients in a study they used muscular technique, and results was very interesting. I think we should have this technique in pool of our techniques because it works well. You can debride all of the dead bone and put cement spacer by Briorif, and after having a good membrane, after 6 weeks, we can put bone graft into the membrane instead of cement. But other than iliac bone graft, we can use fibular graft for large defects. Faldini used fibular graft for up to 10 centimeter of defect in non-infected non-unions. And it worked. For hypertrophic non-union, and they only use a strut graft, and for atrophic non-union, that all of them were aseptic, they used both intercalary and strut graft, and the results, I think, is acceptable. But when the defect is large, as Ring mentioned in previous studies, we should use flap, a bone flap. The best bone flap and the most famous flap is a fibular, vascularized fibular flap. But it's a microsurgical technique, and usually it has many complications and difficulty in technique. This study by Safuri showed that the results of union are well when they use fibular flap, but actually their patients were totally different because many of them had infection and many of them had segmental defect from the first injury. So I think we should consider the context of the study about the patient, but fibular flap is a good choice for large defects and also infected non-unions. Another option for infected non-union like tibia and other parts of body are bone transport. Two studies showed that bone transport can work well, and by unilateral external fixator or Elizarov, we can treat many patients of infected non-union, and the results again were acceptable, but actually I'm not familiar with this technique. This is ring external fixator, and the results of their study from Egypt, I think, very interesting. But I wanted to introduce another technique that Dr. Kamrani from Iran and their team, and that I was a contributor also, worked on that, and it's localized pedicle flap of forearm. Dr. Kamrani did 3 studies for treating both aseptic and septic non-unions. The first study was only for aseptic non-unions that they used posterior interosseous bone flap. This technique was very interesting. I think that most hand surgeons without complex facilities can do that. They removed a bone flap with pedicle of posterior interosseous, both in retrograde or anterograde. We can use that for treating an aseptic non-union. And the results was very good in a small series. And you can see that the place of bone graft can be filled automatically after a while. The second study was using radial forearm bone flap from radius for using both aseptic and septic non-unions. And again, a bone flap from distal radius with radial artery is rotated on the non-union side. This technique has this advantage that, as you see in this picture, we cannot remove all of the non-union side because in aseptic non-unions, and the length of the forearm can be maintained. Only the one side should be removed, and a step is created on the non-union side, and the vascular flap inserted on that. And the results was actually interesting. And the last study was using posterior interosseous bone flap for infected non-union, that it worked well again. And all of the patients healed with good functional outcomes. This is the last study. You can see that for septic non-unions, we should have a good debridement. This part shows that the pedicle of posterior interosseous bone flap, and this is the flap that inserted behind under the plate, the new plate that we apply. And the functional and the healing outcomes are very good. And another study that I think is from January 2022, it's very interesting that in this study they used only periosteal pedicle flap of posterior interosseous artery. It means that they only use the periosteal flap without any bone, and for some of their patients they use cancellous bone graft beneath this flap, and without any bone, without any more considerable donor side morbidity, and their results was good. But the point is that in Dr. Kamrani's study, they could harvest about maximally 11 centimeter of graft, but for this study, their maximum was only 5 centimeters. So by PIBF, posterior interosseous bone flap, or radial forearm bone flap, we can cover large defects like fibular flap. My take-home message is that ReORIF and bone graft work for up to 6 centimeters defects for forearm non-union. Controversy about type of graft, type of fixation will continue, but we have to pull off techniques for treating these patients. For larger defects and infected non-union, pedicle flaps, especially local pedicle flaps, can work. But overall, the union rate is high, and functional outcome on the basis of the first injury usually are acceptable. Thank you very much.
Thank you, Amir. Long time no see. I wish see you soon. Unfortunately, we are in the critical shortage of time and there is no additional time for question and answer. But as the room is still open, the audience can ask the question in the Q&A section and the lecturer will answer it. Thanks for all the panelists of the second session, Dr. Hauseman, Dr. Zanjani, Dr. Arabzade, and Dr. Farhood. I excuse Dr. Tahami for over-lengthening our session. After a short clip, I think we directly switch to the next part of the Congress. Thank you very much and have a good night.
Thank you all.
Thank you, Dr. Hauseman.
جوینت آریکس محصولی است فوق‌العاده که حاوی سولفات گلوکوزامین و متیل سولفونیل متان یا همان MSM است. علاوه بر این، جوینت آریکس حاوی سیلیکای ارگانیک برگرفته از بامبو است که به همراه ویتامین C میتواند مؤثرترین مکمل غذایی جهت کمک به کاهش درد و بهبود استوآرتریت باشد. کمک به کاهش تورم غضروف‌ها و ترمیم آنها از مهمترین ویژگی‌های جوینت آریکس محسوب می‌شود که این محصول را برای بیماران مبتلا به آرتروز مناسب می‌سازد. این محصول به دلیل داشتن MSM و عدم وجود سدیم برای افراد دیابتی و دارای فشار خون قابل استفاده است.
Hello, everybody. Thank you for being with us. Hello, Professor Stannard, Professor Baumgaertner, Fred, Walid, Mauricio, and Seyyed. I want to thank all the faculties and delegates for being with us. And since we are a little bit late, we are going, and our faculties all have allocated their time for this period. We are going to start the session. The session is focused on knee fractures and also tibial fracture. I must say that at first I must thank all our faculties that with all of their work, they accept our invitation to be with Persian Orthopedic Trauma Association. I want to start with Professor Stannard. Professor Stannard is head of Department of Orthopedics in Missouri University, and he will talk about distal femoral fractures, the problems with retrograde nail. Thank you, Professor Stannard, for being with us. Would you please start?
Sure, thank you. Let me share my screen real quickly. Okay, hopefully that is showing up. All right, can you all see that?
Yes, yes, good. It's clear. Yes. Thank you.
Okay, I will get going. So I've been asked to give a very quick talk on distal femur fractures and some of the challenges and the risks with intramedullary nails. And first, I want to very much thank you, Mohammed, and everybody who is involved with allowing us to join you at least virtually. It's good evening to you. It's good morning here. I hope one day we're together again soon, but thank you for having me. Let me advance. So this is a case that could be a place that one would use an intramedullary nail. And at the end, if time allows, I'll show you how I used it. But this was a patient that was involved in a tornado injury, so a very bad windstorm that we have occasionally in the United States, and they can be very destructive. And the patient had an open femur fracture, but with a large amount of bone loss, 10 centimeters. And so this is a place where I did find a use for an intramedullary nail, and I'll describe that at the end, again, if time allows. But the problems that we have with these include the very short distal segment and then the missing bone. So my teaching goals during this are to briefly discuss a little of the key anatomy, just as it pertains to the use of intramedullary nails. And then I want to talk about some of the challenges with nails. I think they're very important, but I also think that they can have problems if you're not careful. And then we'll talk about the advantages really briefly and then spend the time on the concerns. These are very complicated fractures that historically have had bad results, with especially malunions and non-unions. However, over the course of my career, I really think that we have made huge advances in how to take care of them. And our real big contemporary options are use of the retrograde nail or locking plates of one sort or another, variable angle or otherwise, or sometimes a combination of both in certain situations. However, they still can easily have poor results if you're not careful. What's the goal? It's what our goal is for any major fracture. And if we want to get our length, alignment, and rotation restored while maintaining fracture blood supply so that it can heal. But because this involves a joint, I think we also want to be very careful about getting enough stability that we can move the joint early. Because if not, you can have a beautiful x-ray, but a non-functional joint. So I think that's what's different when we're getting into articular fractures. What are our technical challenges? Well, I mentioned one, that short distal articular segment. They're often comminuted, and that can be a problem. The comminution's missing here because the bone was missing. The bone loss that you can see with open fractures that you can see in this one. And then you have to really be careful about sagittal plane malreduction. So that one's not too bad, but you'll frequently see them go into this hyperextension or apex posterior malreduction. And then osteopenic bone is frequently a problem, especially in this era with periprosthetic fractures. Getting a reduction can be very difficult. And when we're doing an intramedullary nail, we're often trying to do an indirect reduction. So by the books, you could accept some translation and a little bit of varus and valgus, but no hyperextension. How do you get the reduction? And for me, one of the real keys is getting that sagittal plane alignment so you don't get hyperextension. And Phil Krieger taught me long ago that you need to learn the fracture before you get hardware in the way. And to do that, I will look carefully on a lateral and I will take a roll of towels, a circular bump, and move it backward and forward to get the reduction. That way you don't end up with that. So another thing to keep in mind very carefully is that we need a very accurate reduction before we start to ream for the nail. If you don't have it well reduced and you ream, you'll never get it reduced. It's very hard to undo it if you make the mistake of reaming before you have a good reduction. So be careful of that. In the literature, you can use nails, in my mind, mostly for type A and C1-2 fractures, but whether you should or not is what we'll talk about in a minute, and when should you. It's very, very important if you're going to do an intramedullary nail that you get the start point correct, or you can damage the PCL. And I will show you in a moment that I do think there is a price to be paid in terms of the articular cartilage when you do these. So it's very important to just realize that and make sure you're using it for a good reason. So when you have a good lateral, what you want to do is get the start pin at the apex of Blumensatz's line. So right there. What you'll often see is that people have the start pin that's away from that apex. If it's away from the apex, it usually means you're sitting too far medial. So look to get it right at that apex as I showed right here. Then you're ready to go. You got to get the start point right or you'll cause damage. The most common deformity is what you see here. So somebody nailed this fracture, but they let it sit in hyperextension, or they didn't control it by the use of other techniques such as blocking screws. This is very hard to salvage if you already reamed it in this position. So be very careful to get and maintain your reduction before this happens. Remember that when you're nailing a distal femur, it's a little bit like putting a stick up the end of a trumpet. It's wide at the bottom, and so it can move back and forth. And it's called the bell clapper effect, where you don't have good control of the bottom of this fracture unless you get cross-locking screws and or blocking screws. And that's what you have to keep in mind. So remember, the distal femur is wide, so it's less stable. The blocking screws can help. Ideally, place them proximal to the fracture if you can to get rid of that bell clapper effect. And this is discussed nicely in a Journal of Orthopedic Trauma article from about 4 years ago. Other potential problems with retrograde nailing include open injuries. You always worry if you're nailing a femur fracture that's a bit higher up that was open, are you then going to allow bacteria down into the knee? So it's a theoretical concern at least. It rarely occurs, but keep it in mind. Bad articular comminution can be very hard to deal with the nail. You have to put it together first with screws. And in that case, for me, usually this becomes a plate case. That short distal segment can be tough, although our nails are much better than they used to be. And it used to be, now we have many more screw options. So you can handle a shorter segment than you used to be able to, but that's still a problem. And then knee contracture arthrofibrosis, and I'll show you an x-ray of one that got that. So you have to really watch that because it can create a patella baja that's hard to treat. And then finally, damage to the PCL or the articular cartilage. So this is a video I want to show you. And I was asked to take care of an unstable ligament situation. And I went in and they had a retrograde nail placed about a week before. And the things I'd show you is look at how much articular cartilage fragments are sitting there, and then watch this video. So as I play this, there's the patella, there's the trochlea. That's the retrograde nail hole that you're looking at right there. The notch is down now where my probe is. So look at the size of that hole. And then I have many people tell me, oh, it doesn't hit any cartilage that the patella or anything else actually goes over. And I will argue that that's not true. Watch when I range this knee now. I'm about to flex the knee. Look at what that patella is doing. It's going right over that hole as we flex this knee. So you need to understand you're creating a 13 or so millimeter defect in the articular cartilage. And if you think that it's not articulating with anything, I don't think that's true. So what about patella damage? So this is a case I saw where somebody used a complicated case. They had a hip fracture, and then they placed this retrograde nail, but they left the nail a little too long because they ran into their screw. And what I saw was the nail sticking out, and then look what happened to the patella as a result. So you can't leave the nail long no matter what you do. How about damage to the cruciate ligaments? This is a case where someone put the nail too far down into the notch and they took out the PCL. The patient already had a torn ACL, so functionally they created a knee dislocation. You can't do that. You've got to get that start point right, and that gets back to what I talked about a little earlier in this talk. Patella baja can be a problem. You're dealing with the joint. Many people go through the patellar tendon. Some people go next to it. You can do it either way, but recognize that if you create a situation like this, where a patient has this kind of patella baja, that is going to be very difficult to end up with a good knee. So key questions for me that I ask is, do I need a retrograde nail? Because it isn't as stable as a plate, and it has the risks I just talked about. And then the other question is, do I have a good option that doesn't invade or go into the knee joint? If so, I will frequently use that. Why use a retrograde nail at all then, you might say? Well, if there's significant soft tissue damage that makes it very difficult to do the approach for a plate, that's one reason, because I can do it with a much smaller approach. If it's an unstable patient where larger blood loss could be a problem, then that's a good reason. So that's another reason to consider it. And then I'll show you, if we have a moment at the end, using the nail with that bone loss. And that's what it looks like, but I'll explain that in just a second. This is the cage and nail technique. So if you do have a lot of bone loss, you can take one of these spine titanium cages, run a nail right up the middle of it, and then surround it with bone graft, lock it proximally and distally, a little bit like what you see there. I use the Reamer irrigator aspirator for bone graft, but get bone graft however you want to. That's what it looks like. And you can take a big gap like this, and you can fill it with this titanium cage. That lets the weight bear almost right away, and surround it with bone. And over time, it fills in and becomes a very viable situation. That's what it looked like as it started to heal. And they were full weight bearing within about 4 weeks. wound healed, they got great knee motion, and it led to success. So it is one of the places where I think it's worth making that hole in the articular cartilage. So quickly drawing this to a close, what are the take-home messages that I would have for you? First thing is, retrograde nail is a very important technique. I'm not suggesting it shouldn't be used, but there are some dangers with it, and I think it's very important to recognize those. I tried to highlight some of those, but the problems basically are either obtaining and maintaining the reduction. That's that wide distal femur and the bell clapper effect and the lack of good control down where your fracture is. You can make up for that with multiplanar interlocking screws and then with blocking screws. Knee damage is the second one. You can damage the trochlea with that big hole. If you leave it long, you can damage the patella, as I showed you, and then you can take out the PCL if you're not in the right place. You can fix that partly by being in the right starting spot, but you're still going to damage that articular cartilage. So make sure you have a reason for doing it. And then third, motion problems. You can get into arthrofibrosis and patella baja because you're invading the joint and you're creating scar tissue. So again, for me, is there a reason why the nail is the right answer? And if there is, then I think it's a great technique, but realize these potential problems. And finally, that risk of a septic knee if it was an open fracture. Don't violate the knee joint unless you have a reason. But when you have a reason, a retrograde intramedullary nail can be a very, very important tool for us to take care of these difficult fractures. Thank you very much. And again, thank you for allowing me to join you.
Thank you, Jim. Thank you so much for this great lecture. And I must also emphasize that Professor Stannard is very well known for his knee reconstruction and knee reconstructive procedures and also trauma. And the next speaker is a professor from Yale University, Professor Baumgaertner, who is well known for his tape apex distance measurement. And he's going to talk about complex tibial plateau fracture and planning and decision making. Thank you, Professor Baumgaertner, for being with us.
Thank you. I hope you guys can hear me and see the screen. Is that true?
Yeah, that's true.
Great. So it is an honor to present to the organization, and I will discuss complex tibial plateau fractures, planning for them more than anything, and then using that thoughtful plan to carry out a fixation construct. I hope that we can describe how to acquire and interpret just not only standard x-rays, but multiplanar CT scans to help us. I want you to explain how the initial fracture deformity drives the appropriate implant construct that you're going to apply. And lastly, employing thoughtful planning to determine the approach, the read, the specific marker you're going to use to identify the reduction you're looking for, and then importantly, the sequence in which you achieve these steps to stabilize allows you to do something with really a minimal biologic insult, and it makes it fun. So obviously planning with poor imaging is not planning, and you need x-rays that are centered at the knee and a true AP and lateral, and I just use the patella for the AP and the condyles on the lateral. Remember though that an AP of the knee is not tangent to the plateau. That's going to be about 10, 12 degrees off. And that's critical when you're first of all diagnosing, but also determining whether or not you've got a reduction. So here's the AP view of a fracture, and here's that plateau view. And you know that because the normal joint line is a tangent. It's nice and white. And that shows you the difference between the normal and the abnormal side. And that's going to be critical interop to know what you're actually looking at, because you got a very unstable fracture pattern. So here's, and then lastly, a CT scan is going to be essentially required for these complex fractures, but only after you've pulled it out to length and gotten a reasonable reduction. And here's just such a case where we see with the CT and distraction, we see the impaction and we see the fracture lines, but we also see on the surface rendition not only the very distal impaction, but look at how clean the lateral fracture line is. That's one that you can get a read on directly. And since there's no impaction proximally, that could be a buttress for your reconstruction. And so in this case, we put a temporary plate laterally where I knew it was reduced, and that allowed that lateral column to buttress a distractor medially where I could dial in a relatively unstable shear fracture to perfection. And that we buttress in a typical fashion to support that. And then we can go back to the lateral side, elevate up the joint, remove that temporary buttress, and apply a buttressing plate as you see here. So the CT didn't really change what I was going to do, but it really facilitated the sequence in which I did it. And I think that made this case, for me at least, go easier. Now let's look at this one. Now, if you look at the AP, it really doesn't look all that exciting. But again, look at the difference in the slope of these two plateaus. One, you're getting a tangent. The other, you can't even see. And on the lateral, you see why. You've got a very depressed medial plateau, and you've got a very impacted posterior lateral plateau. So those are very different, but they're both grossly pathologic. And again, now if we go to the CT, we can pick up this surface rendition, and you can see the a little bit of comminution medially, but look at the slope of the lateral plateau and the fibular head and neck fracture. If you're going anteriorly, you'll see none of this. I mean, this is going to be a real swing and a miss if you approach this anteriorly. So with these tests, in this case, we go pretty much routinely. We're going to go medially, and we're going to elevate up the medial plateau, leaving that lateral impaction alone. And we'll buttress medially with care to avoid any screws into the lateral side. But now that we have that medial buttress restored, we can go laterally. And in this case, through the fibula, transfibularly, we can elevate up and see, we can see that markedly impacted depressed lateral plateau, and we're in a position to perfectly buttress it, exploiting that fibular fracture. And here we see that angled T-plate that'll really wrap around there and hold that reduction laterally. And so here's the bilateral AP view at follow-up to really kind of judge your results and allow you to see that you've achieved what you'd hoped to achieve. Now, what about this fracture? Where would you approach this, and where would you put your implants? Clearly impaction. And it looks, this is pretty much, to me, looks all anterior. And that is, there we go. On the CT, what you see is, in fact, marked comminution anteriorly. But notice posteriorly, you've got distraction failure. Your fibular head is avulsed, and you've got a clean tension failure posteriorly. So that's going to drive me to an anterior distractor based on this information that's going to put me in a position to go from the front. I'm getting a delay here on my CT, sorry. Go from the front to elevate up and use the posterior cortex as a fulcrum, and then with significant bone grafting and anterior buttressing, you hold that fracture with a return of what appears to be a pretty normal slope. In follow-up at 6 months, you can see these dual anterior buttressing plates, and there is some, it's not a great AP, but the lateral shows that there's some loss of that elevation. But I personally, I don't know a way I could have held that up any higher. And going from the front, because that's where the fracture had to be, I think is the best I could do. This is the last case I'm going to show in this quick little talk, but this was a real learning point for me. And I struggled with this. This is a 14-year-old who had he had a compartment syndrome that my partners caught and decompressed and spanned him. But he had this Salter 4 fracture right through the critical component of his medial joint line, and the entire joint was otherwise depressed. And here you see on the reformatted 2D CTs the drop off of most of his joint, with just this sliver of medial plateau. And on the reconstructed views, again, you see a very malignant coronal fracture line in a 14-year-old on his medial plateau. And on the posterior view, you just see how this, about 80% of this joint is impacted down. And I just really was struggling how I could get the mechanical force to bring that up. And I was, the night before surgery, I was staring at this thing, and I don't know, maybe you guys figured this out, the minute you see it, but I finally saw the fibula and damn, if that isn't just a beautiful jack to jack up that entire joint line in a very powerful and atraumatic way, then and once I've got overcome that force, the rest should be easy. So in fact, we started prone, and you see the little x-ray, that's the position of the clinical view. And that fibula did not want to budge. But once you put, you can overpower that with a distractor. It's a diaphyseal fracture. We dialed it out to length, as you can see here, and held it with a single screw. It doesn't take a lot of metal once you've taken advantage of the anti-glide property of that fracture line. You hold that side. Now your entire joint line is grossly up to where it should be. And then we can simply go posteromedially. You can see the alignment of this clinical picture with the x-ray above. And we can dial in with a very, without having to deal with the forces of moving that proximally, just rotate that segment into position and buttress it with a plate. And you can see here on this close-up that we use the physeal scar rather than the joint line to get that reduction about as perfect as you can. It's a line-to-line reduction. And really, for me, it was just a great case to be able to think about it and have the time to think about it and figure out an effective sequence of events to get us to this position. My partner came in a couple of days later arthroscopically and tagged down his ACL footprint. And you see the final result a year later in this kid who hopefully doesn't really even remember what happened to him. This was a few years ago. So in summary, I hope that you understand the importance of using your imaging and your initial deformity to decide where your implant needs to go. And even though most of the time you're going to go posteromedial and anterolaterally, as these cases show, not always. And then think and reflect what the CT tells you about where you're going to read your fracture and what sequence you're going to use to carry it out. And then lastly, I hope that you use your final imaging, get bilaterals, look at the difference, and just use it to make yourself better the next time. It just makes practice and your career a lot more fun. Thanks for your time. As Jim said, it'd be great to see you three-dimensionally, but maybe sometime in the future. Thanks again.
Thank you so much, Professor Baumgaertner, and I hope that in near future we can have you in our country and have a live event with each other. The next speech is about half a fracture, and I'm to the excuse me. Sorry for the inconvenience and error. By the way, after these two great lectures on the distal femur fracture and plateau fixation and decision making, we are going to talk a little bit about half a fracture, although they are rare, but the diagnosis and treatment are so much important since the disaster of untreating these fracture may make the patient that to have dysfunctional. By the way, I'm going to define the force beneath it and also to review a commonly used approaches with a focus on fixation construct that are routinely used. Back to 1905, Hopper described this pattern. Afterward, the epidemiologic studies reveal that these fractures comprise less than 1% of all femoral fractures. By the way, they're happening in the patients with multiple trauma. The mechanism of injury is mostly due to high energy trauma with the lateral side due to a force that inserted directly from a onto posterior direction to flex an abducted knee, whilst on the medial side, that the cause is a direct medial force to flex knee. Sometimes the patient may have different pattern due to vertical shear and twisting injuries. And why these fractures are unstable, since they are located in the boundary between patellofemoral joint on the proximal part and tibiofemoral joint on the distal part, with consideration that in the back we have gastrocnemius and popliteus muscles, all are working together to make these fractures both unstable in coronal and sagittal planes. How about classification? Although we have not too much classification, we have Letenur, which is not validated and it depends on the fracture line and its space from the posterior femoral cortex. By the way, the most well-known is AOTA, in which the half of fracture has B3 subgroup. This is a very important study from Schoenort, that they showed us that in supraintercondylar fractures, there is a 40% chance of having coronal plate fracture, most of them on lateral side. And the presence of open fracture may increase the chance of HAFA about 3 times more. So they suppose and propose to have CT scan in all open supracondylar fractures, not intercondylar one, supracondylar fractures. By the way, sometimes they are occurred in the situation of a knee dislocation X-ray is not always straightforward. There is about 30% chance of misdiagnosis if you are going to trust only on routine X-ray. So the modality of choice here is CT in case of there is suspicious of having HAFA fracture. How about management of these fractures? They obey the rules of all intra-articular fracture parts, which we need rigid anatomic fixation. So there is no role for conservative treatment, and also fluoroscopic assisted fixation is inaccurate since the corridor of screws are not too much validated. How about approach? Our approach depends on the way that we need to see the fracture line, and we need to see the screw penetration on the region. Also depends on the fracture configuration and presence of associated fractures. We can use different approach, but the most important one in selection of approach is the surgeon experience itself. How about fixation construct? There are small fragment screws which can maximize the screw corridor, especially in case of using a laterally fixed angle implants. And they also provide less cartilage removal during countersinking. And especially in case of a smaller fragment, they are so much helpful. On the other side, large fragment screws, they are more stable construct, but they can complicate the fixation construct in case of using a fixed angle devices, and also they require more cartilage removal. Biomechanically, using 6.5 millimeter screws are the strongest and much more strongest than 3.5 screws. By the way, the least stable constructs is 2 3.5 millimeter screws. How about plating? Is there a role for plating? Yes, in case of comminution or osteoporosis, when there is a large metaphyseal bead, we can use a plating system. How about direction of our screws, AP or PA? It depends on the approach, fracture configuration, size of fragment, and almost the AP direction or AP screws are much more common. Biomechanically, There is less displacement in use of PS screws, especially with vertical loads. And on the other hand, the PS screws need to be more countersunk and they are more difficult to insert. How about headless screws? They are both small in size and length, and we need much more than 2 screws most of the time. Using all the rules of intra-articular fixation, usually the outcome is not so much bad. And they are reported in the literature that if we use the anatomic reduction and rigid fixation, usually the outcome is good and can improve over 1 year afterward. By the way, there is a difference in prognosis considering the medial side and lateral side, and medial half of fracture have a little poorer prognosis considering the lateral one. There are also complications reported in the literature. One is delay union and non-union, especially in case of conservative treatment, and avascular necrosis, hardware loosening, infection, and prostate fractures are all reported in the literature in not so much high rates. Let me show you 2 cases of our center. The one is a 59-year-old man, a case of car accident that was brought to our center. And as you see in the lateral X-ray, he's suspicious of having a half a fracture, which was also confirmed by CT scan. And in CT scan, there was also a kind of avulsion fracture of head and fibula. So we were suspected for this patient of having knee dislocation and perform an MRI. And in MRI, although there was fracture of medial half apart and head of fibula, but PCL and ACL were intact. And in this video, you can see the physical examination in the OR theater, which shows the lateral and also posterior laxity prior to our fixation. We use the medial subvascular approach, and here you notice there is also an impacted osteochondral fragment accompanying the half of one. After reduction of the impaction and also temporary fixation of the half by K wires, we fixed this by 2 cancellous 4.0 screws and also an anti-gliding plate. And you can see the final result about 3 months after the operation that the patient can bend his knee about 100 degrees and can walk without any aids. And let me show you another case, although it's rare, that 56-year-old lady operated in another center and came to us 10 months after operation with length and limitation of motion. She was treated as having supraintendicular corneal fracture, and as you see, had these non-union bilateral half of fracture. Prior to our schedule for operation, she experienced falling down, and after that, we have this problem, a non-union of bilateral HAFA, and on the other hand, is kind of supracondylar fracture. The only option that we think to preserve her bone was to use NCB, non-contact bridging plate from Zimmer Biomet, and fortunately, after 6 months, she experienced healing of both fractures, and you can see the final physical examination of the extremity that was operated. By the way, in summary, the only important thing in HAFA treatment is not to miss them. And here, CT is of paramount importance, especially in case that we have a red flag sign of the accompanying HAFA fracture. And we must obey the rules of intra-articular fractures, which means anatomic reduction and rigid fixation. Usually 2 AP, the 3.5 screws are suffice if they are inserted perpendicular to fracture. And we must have in our mind that there may be a role for plating in case of comminution and the large metaphyseal part or osteoporosis. Thank you so much. And we are going to continue with our next speaker. Professor Kfuari from Missouri University. Thank you, Mauricio, for accepting our invitation. Mauricio is a very well-known surgeon about knee sport injuries, and also I think he's AO Sport Task Force, and he has published the revisited short scale classification article, which is very well known in our country. Mauricio will talk about treatment of tibial plateau rim fracture. Thank you, Mauricio.
Thank you very much, Mohammed. Let me share my screen. All right. I hope you can see my screen now. So, hello, everyone. First of all, thank you very much for the opportunity to be here with you today. It's a pleasure, it's an honor to attend this meeting at the Persian Orthopedic Trauma Association. I also enjoyed very much all the talks I watched so far, and it's always an opportunity to learn and pick new ideas. So I'm going to talk about the concept of the tibial plateau rim fixation. And basically, these are my disclosures. The objectives. We hope that at the end of this presentation, the learner should be able to understand the functional anatomy of the tibial plateau, recognizing that the split wedge fragment is the key element for tibial plateau stability. And also, we hope that the learner can differentiate the importance of congruity versus stability. So let's go to basics, surgical anatomy. So the tibial plateau, no discussion about it, has two condyles, lateral and medial, as you can see here. Therefore, two columns. And what's very interesting is to pay attention to a detail that has not been very much explored so far, that the tibial plateau has two distinct areas, the area which is covered by cartilage and the area which is basically bare bone. This is a very important distinction. I will explain to you why. Because when it comes to the areas covered by cartilage, the main function of these areas are to distribute the weight, and it's a critical thing to achieve congruity there, because this is where you want to achieve congruity for the joint. This is where the femoral condyles are going to roll on. And the technique that we normally try to use to address fractures in that area is basically anatomical reduction, absolute stability whenever possible. Not necessarily is going to be possible for every single case. You all have dealt with fractures where the surface was completely crushed, and it was not possible to establish anatomical reduction. And this is where those concepts I'm sharing with you, I hope, could be very helpful. The other area is the area where you have no cartilage. And now we are talking about the tibial plateau rim, and we are also talking about the intercondylar area. What's the interesting thing about these two areas? Those are areas where you have attachment of the capsule and attachment of the cruciate ligaments. So what this means, those areas are critical for stability. Once you restore the anatomy of this area, you are restoring stability mainly. So, and it's a critical difference. And I hope this could be an interesting thing to discuss. Again, we have different goals of treatment for the two different areas of the tibial plateau. We have congruity, which is our main goal when we talk about the cartilage-covered areas. And we have stability when we go for the areas for where we have bare bone. Then we go to the classification of tibial plateau. I'm very honored to have shared this work with Dr. Schatzker, who is my mentor, and we have worked together since 2008. So basically, what this classification gives to you is, again, go back to the basics of anatomy, giving you anatomical landmarks to tell you where is anterior, where is posterior in the tibial plateau, because so far it was possible to say this is lateral, this is medial. And what's going to determine what's anterior and posterior is the attachment of the MCL and the LCL. So basically, if you go to these two attachments, this is how you know when you have to go to the back and when you have to go to the front of the tibial plateau. Also, this article talks about the split wedge piece or the split wedge fragment, which is the key determinant of stability. And what determines the split wedge is always going to be 3 points. 2 points where the split wedge is going to bisect the tibial rim, and the other point where the wedge exits the metaphyseal area, as you can see. And you may have more than one split wedge. Finally, we talk about having a tridimensional location of the main fracture plane. And why does it matter to know where's the main fracture plane? Because then you know where you'd like to have your thumb, where you'd like to support that key element, which is the split wedge fragment. And once you know where you like to have your thumb, you already know your surgical approach because you know where to apply your buttress plate. So basically, when you restore the rim of the tibial plateau, you restore the continuity of the tibial plateau. The only thing that's going to prevent this split wedge fragment to displace again is a buttress plate, which should be parallel to the main fracture plane. This is where you have your fracture exactly fixed in the way this is shown in this particular illustration. And again, if you know where the plate has to lay, then you know exactly where you do your surgical approach, in this case, posterior to the MCL. Let me exemplify the idea of containment. So this is a very osteoporotic patient, 77-year-old. And if you look here, there are two main problems. Besides osteoporosis, she had a anteromedial compromise of the tibial plateau, but also she had a inferior pole avulsion of the patella at the time when she fell. So this is a type 4A according to the new classification. And what we want to go, we would like to buttress and contain that tibial plateau rim in a way that we can restore stability, because this joint is going to be unstable. If this lady tries to bear weight, the condyle is always going to follow the area of displacement of the split wedge. We started with femoral distractor for ligamentotaxis. Then the first thing we did was to apply a buttress without thinking about reduction or congruity of the joint first, just trying to restore the rim or restore the split wedge piece. And this is how we were able to buttress that piece. And then we open another window just to improve congruity by pushing those pieces up. And this is what we obtained after having containment for the tibial plateau. We were able to push those joint fragments up, and then bone grafting, and then final construct, and final reattachment of the inferior pole of the patella. So long story short, we believe that the article helps surgeons to understand the concept of instability, what brings instability to the joint. Every time when the tibial rim is no longer in continuity, the joint is unstable. The tibial plateau rim concept. We explained that the rim fixation is a critical thing because this is the only thing that prevents the split wedge to displace again. And you can obtain rim fixation with longitudinal plates, which are applied to the main fracture plane of the split wedge, or sometimes you have a crush of the rim, or you have a fracture where the height of the split wedge is not longer than the width. And for those cases, we advocate for the use of horizontal buttress plates, which are going to follow the contour of the tibial plateau rim, as you can see in this illustration. So let me show you some cases. This is a patient that had this particular injury, high energy trauma bicondylar, mostly in the coronal plane, also with an ACL avulsion in displaced tibial spine, which is a relevant information. Here you see the 3D. So areas of instability for this patient: posterolateral, because he has a posterolateral disruption of the rim; posteromedial, because the posteromedial rim is disrupted as well; and then the tibial spines, because this, you could see that the ACL is very displaced there. So how to address all those things together? This was the dilemma we had. So we decided to go posterior-medial first to reduce that. You can see that reduction of the split wedge fragment, but also we had to address the posterolateral depression. And we decided to do the lateral epicondyle osteotomy because this gives me not only access to the entire tibial plateau lateral rim, but also I can extend it and can see very nicely where my ACL attaches, and I can reattach my ACL. So this is the view intraoperatively with the femoral destructor. You can appreciate the comminution of the posterolateral rim. You can appreciate the comminution of the ACL area. And this is not an ideal case for screws because there are multiple pieces in the area of the ACL attachment. This is how we contain the rim with a posterior hook plate, which we inserted from posterior medial towards posterolateral through a corridor in the back of the knee in front of the capsule. This is the hook plate that has been described already by my colleague Giordano, myself and Joe Chatzker. And this is what we did with very basic instruments. We reattached the lateral epicondyle with a very long screw, unfortunately, but we were able to fix all those injuries with small fragment sets without locking plates. After I removed that screw, this is how the knee looks like after 3 years. The alignment is neutral. The patient has no pain. The CT shows that the congruity was not perfect. And how is this patient so happy? Because he's stable. I was able to reattach the ACL. We were able to reattach or reconnect the rim. And even if the congruity is not perfect, this joint is stable and this patient is functional, as you can see. And you can see the patient walking. He has no instability when he walks, and he has no pain, and he is involved with heavy duties. Another case, this one came to me 5 weeks or 4 weeks after a knee dislocation. This was the knee dislocation when she had the injury. She was referred to the University of Missouri. She came from Oklahoma for this treatment. And this is what she had. She had a type 4 dislocation. And when you have a type 4, always pay attention to the posterolateral corner. And she did have an injury to the posterolateral corner. So the steps for this case were to restore stability first. So how to do it? So basically, the rim is completely out anteriorly. There is a posterior medial fragment. There is also a posterolateral corner injury. The spines are also deviated some. So this is how we reduce the tibia under the femur. Then we fix the medial column. And in the same time, we also did a rim plate anterior underneath the patellar tendon, just to connect the quadrants of the anterolateral and anteromedial pieces. And then we did the posterolateral reconstruction that you can see here, the resorbable screws there. And we did a posterolateral. This is not a great X-ray, as Dr. Baumgaertner mentioned to you. This is not a plateau view of the knee. But this patient, again, had a very good outcome with a very stable joint. Even if the joint is not 100% congruent, it's a functional joint. In summary, I shared with you the concept of having to look at the tibial plateau, paying attention to two different anatomical functional areas, the areas where you have cartilage, the areas where you have attachment of soft tissues. I also showed you that the key element for stability is the split wedge. And this is why the split wedge has to be reduced and buttressed, because this is what restores stability to the joint. And the way to do it is with either longitudinal or horizontal or both plates in the very same set. I've done both already more than once. And consider horizontal plates when you have situations where you have a crushed rim. Very important. Congruity is always what we try to pursue, but sometimes it's not achievable. And the consequence is going to be late arthritis. Stability, sometimes it's difficult to achieve, but most of the times you can achieve stability when you reduce the split wedge. And if you can't achieve stability, the problem is this patient is going to be acutely disabled. It's not a late occurrence. He cannot bear weight. She cannot bear weight. We always pursue to restore both. But in case you can't, pay attention to the rim, pay attention to the split wedge piece, pay attention to the congruity and continuity of the rim. This is a paper which has been accepted for publication now at the Injury Journal in 2022. You're going to read about this one. We're going to make this available for everyone as we made the classification as well. And we are happy to share this information with you. So I would like once again to thank you for the honor and the opportunity to be here with you with this phenomenal panel of experts and also talking to the Persian Orthopedic Trauma Association. Thank you very much for your time.
Thank you, Mauricio. Thank you so much. Since we are a little behind our time, there is no much time for question and answer and discussion. By the way, we have, I think, 3 minutes for question and answer. Since I'm Shiraz and the headquarters is in Tehran, Dr. Khabiri, is there any other the program for the question and answer, or we must go for the next session after the question and answer? We have some questions from one.
Hi everyone, have a great time. We can use Q&A discussion, and then we can hear Walid Abdul Wahid presentation.
Thank you, Mr. Seyyed.
I think there are no questions. The lectures were great, and the lecturers were also great. Thank you, Jim. Thank you, Mauricio. Thank you, Mike, for being with us. I know your time schedule is so much tight, and it was your honor for the Persian Trauma Association to be with us and have your time free in this period. By the way, I want to say you goodbye. I hope to see you in near future. And we are going to start the next session, which will be on the leg fracture. Thank you so much.
Thank you.
Okay. After these great talks, we are going to continue on a leg fracture. And in this session, we have other distinguished faculties from Germany, Iraq, and Egypt. I want to start with Dr. Walid Abdul Wahid, my friend from Iraq, and he's head of reconstruction center in Baghdad. And is going to talk about tibial nailing. Is fibular fixation necessary? It's a question that we as the orthopedic surgeon may sometime ask ourselves. Walid, thank you for being with us. Please start.
Thank you. Please start the recording. Good evening. I am Dr. Walid Abdul Wahid from Baghdad Medical City Teaching Complex. I am happy to be here in this event among this reputable faculty. Thank you. Our topic today will be about tibial nailing. Is fibula fixation necessary? First, we need points to consider. The level of tibia and fibula fracture in the leg, is it mid-shaft or distal? Then, the level of fibular fracture relative to the tibia fracture. Are they the same level or different? And finally, the personality of the fracture morphology. This means the energy and the stability achieved by the fixation method. And this might determine the type of fixation. How we evaluate results regarding healing is important, definitely, and also the alignment. If we go through literature, most of these are about distal tibia whenever the fibular fixation is mentioned, and less about midshaft. Clinical studies are there. Of course, they are testing certain possibilities, but the mechanical studies are testing wider variety of possibilities. Well, a study from Strauss in 2007 comparing the LCP, locked compression plate, versus the IM nail in distal tibia fracture associated with fibula fracture. LCPs provided more stable fixation than IM nails in vertical loading, but were less effective in bending. As expected, an intact fibula in the presence of a distal tibia fracture improved the fracture fixation stability for both treatment methods, the plates and nails. In fracture patterns in which the fibula cannot be effectively stabilized, LCPs provided improved mechanical stability when compared to IM nails. Another study from Penskova et al. In 2009 for the fractures of the tibial shaft using nail diameters of 9 mm and 11 mm and also applying compression after reduction. So recommend that the largest possible nail diameter should be used with minimal reaming to minimize fracture site movements and achieve the required stability. Also, compression after meticulous reduction should be considered in axially stable fractures. So this is factors that could improve the stability of a tibial shaft fracture fixed by nail. Now we come to test the type of distal locking in the intramedullary nail. This is a multi-center randomized controlled trial about fractures of the distal tibia and fixed by intramedullary nail, comparing the angular stable distal locking versus the conventional locking. From Honses in 2014, no clinically important differences were found in most of the outcome parameters between the groups during the entire follow-up period. So the use of angular stable locking system with IM nail did not improve the outcome compared with conventional locking screws in the treatment of distal tibia fractures. We have now 4 studies were chosen about different anatomical areas in tibial shaft for both fractures of tibia and fibula. The first one is mechanical and it's about midshaft. The other one is distal shaft, AO type 4-2, and the outcome here is non-union. And we have 2 studies, last studies, about distal tibia fractures with fibula fractures, and the outcome here is alignment. Talking about alignment issue, actually the newer intramedullary implant has extended the IM nail indications to more distal and proximal fractures of the tibia. Some surgeons still use intramedullary nail alone, or other surgeons augment it with nailing and augment nailing with the stabilization of the same level fibula fracture, and others have their individual indications for fibula stabilization. As we know, the metaphyseal region offers minimal cortical contact to the nail, and there are increased stresses placed on locking bolts of the IM nail, and it is more difficult to maintain alignment. Stress is magnified in the presence of comminution and of bone loss. Malalignment may result from technical issues and errors or local factors specific to the region. Regarding the alignment issue, we have a meta-analysis from Peng et al. In the year 2020. It is about concomitant distal tibia and fibula fractures treated with IM nail with and without fibular fixation. In the distal tibia fractures, IM nailing with fixation is likely to be associated with lower rate of malalignment than non-fixation group. Of course, this conclusion is only for cases treated with 2 distal locking screws, and as you know, because the modern nails may have more than 1 plane and more than 2 screws in different localizations. And the incidence of delayed union, non-union, and infection did not differ between the groups. This slide is a continuation of the previous slide and study. It showed some details. There were 4 trials, include 283 patients. 94 of them has fibular fixation. And tibia alignment was followed up over time, ranged from 12 to 72 weeks. In that follow-up period, 20% of patients with fibular fixation had malalignment, but 67% of patients in the non-fibular fixation group developed malalignment. So the conclusion that was already given is that fibular fixation was significantly associated with lower risk of malalignment and distal tibia fractures fixed by nailing. Another study about alignment that was published in GOT by Eagle et al. In the year 2006. Malalignment was defined as more than 5 degrees in the coronal plane and more than 10 degrees in the sagittal plane. The conclusion was adjunctive fibular stabilization was associated significantly with the ability to maintain fracture reduction beyond 12 weeks. So the authors recommend fibular plating whenever IM nailing is contemplated in the unstable distal tibia and fibular fractures. Of course, these unstable, that means comminution, bone loss, same level fractures. So this is an important message. These are images from the previous study. On the left is a case of comminuted distal tibia fracture, distal shaft with fibular fractures. The surgeon here needed plating of fibulae in order to hold and maintain reduction. On the right, there is a fracture that a polar screw was used to achieve reduction, and after 3 months, the position was maintained. There's another 2 cases from the same paper. The fracture on the left was mild reduced, and it was revised with the help of polar screws to improve the alignment achieved. While the case on the right of the slide, the post-operative some reduction, which is borderline, and it did not hold position at 8 weeks. We can see it has shifted into valgus. Putting these alignment issues in mind, a question could arise. If fibular fixation is to be done, should we do it before putting the nail on the tibia or after? And would that be a factor, effective factor? This is a study about biomechanics. It involved the midshaft of the tibia, role of fibular stability in diaphyseal tibial fractures that fixed by nail. Actually, fixation of the fibula may not contribute significantly to the stability of diaphyseal tibial fractures and should not be a routine. And also there is like a recommendation that for testing purposes biomechanically, the intraosseous membrane and fibula should not be removed while we are testing stability of tibia nail construct. This slide explains the setting of the previous study. On the image on the left, we can see how testing the axial compression and torsion, while the image on the right up showing the shear load testing, and the image on the right down we can see the 4-point bending. The loads seen in the previous slide were subjected with the fibula in 4 conditions. First one was intact fibula, the second one was short oblique osteotomy of the fibula, and then the fibula osteotomy was fixed with a 3.5 semitubular plate, and then without intraosseous membrane and fibula, only the tibia was tested. And finally, the last study, it is about union as an outcome. It is involved the distal shaft, and it's a clinical study to fix or not to fix the fibula in distal shaft. These are the AO type 4-2, and the authors recommend that fibular fixation in all AO 4-2 distal fractures where the fractures lie on the same plane and the tibia fracture is relatively stabilized. So this is a recommendation to fix in unstable fractures. What would be our take-home message? So in mid-shaft of tibia, the fitting and the technique of doing IM nail is the most important. Attention to details would ensure stability, and as shown by mechanical study, the fibular stabilization will not contribute significantly, while in distal shaft and distal tibia, fibular fixation improves alignment, especially in the unstable tibia and fibular fractures where the same level fractures or where is extensive comminution or there is tibial bone loss. I want to thank all the audience for their attention. Thank you.
Thank you, Hadi, for your comprehensive evidence-based lecture about this challenging topic. By the way, let's start and let's continue with our next speaker, Professor Friedrich Baumgaertner. Hello, Fred. Thank you for accepting our invitation. Fred is a very well-known guy in the AO. He is founder of AO Task Force for Education and also AO Program Editor, and also one of the guys who make AO Playground or many other activities in the AO and also in Germany. Fred will talk about tibial non-union and also is there any role for alignment or device selection considering the tibial non-union? Thank you, Fred.
Well, thank you very much. I hope I can. I don't see where I can. Having little problems with my.
There is a green button at the below of your Zoom application, and when you click on it, you can share your screen with us.
You see it?
Not yet.
I'm having a problem.
Do you have Mac? Do you have Mac or Windows?
I have Mac, and I can. It doesn't seem to work. I see you, but I don't. Because I'm okay.
Mr. Guran, is there any difference between Mac sharing and Windows sharing?
Yeah, I think you need to access to your Mac for sharing your screen. I think you should go to the preferences, and there is an option for recording a screen. You should access to your Safari for. You should access to your Safari for sharing your screen, recording your screen.
We have also Fred lecture with us. We could also play it in Tehran, and Fred can talk on his lecture.
Man play کنم.
Let me see. For some reason, I'm trying to get my.
We can play your lecture here in Tehran, and you can talk on your lecture.
Okay.
Mr. Guran, would you please?
Just a second.
How do I change?
Okay, just a second.
Can you share it to me? Because every time I go to sharing it, I see you again.
Yes, they are trying to share your.
Yeah. I share it for you, and you can talk on your presentation and say to me for next slides, okay?
Okay.
Okay, can you see your slides?
Yes, I can now. Okay.
Okay, go ahead. Thank you.
Next. Okay. Excuse me, there's some here. Okay. So thank you very much for your invitation. I'm sorry that the technical aspect here is not perfect. So, but I actually wanted to share with you some thoughts about bone healing. So what does nature do with a broken bone? It usually heals by callus formation. If there is motion, a certain amount of motion between the fragments. Change. Go on, please. And if we look at fracture healing, we start with inflammation, which encompasses the hematoma, mesenchymal cells, and then it goes into soft callus, which has granulation tissue. And then from the soft callus, we go to the hard callus. But if there's excessive motion, then we have failure in bridging. And so the step between soft callus and hard callus is interrupted. There is no remodeling. Then we have non-union. Thank you. So the definition of non-union is the fracture has ceased to show any evidence of healing, usually declared between 6 and 8 months. It has no possibility of healing without further intervention. So these are all causes of disturbed bone healing. Now, we can have poor vascularity. This is biology, meaning traumatic, disturbed bone healing, or intraoperative iatrogenic. Yes? What about instability? Instability means inadequate stabilization and bone resorption at the fracture site in simple fractures. Yes? Infection. Infection means bone destruction at the fracture site, loss of stability, loosening of hardware. And of course, we have non-compliance, inappropriate weight bearing, smoking, improper diet, neuropathy, diabetes, paraplegia, chronic alcoholism. All of this can disturb the bone healing. The diagnosis is not only history, but clinical signs of pain, swelling, and redness, motion at the fracture site, progressive deformity, and malalignment. So we need serial x-rays. We have to look at implant loosening. We have to see irritation callus if we want absolute stability. These are signs, the radiological signs of non-union. And if there seems to be an infection, of course, we need the lab reports, the CRP, microbiology, and some sophisticated radiology. So classification, diaphyseal, that's what we want to talk about now, diaphyseal of the tibia. We can classify because of the callus, and we say, okay, we have hypertrophic callus, which lacks stability, but usually has a good vascularity. We have atrophic callus, lack of bone response. We don't see anything happening, this in spite of vascularity. This is usually multifactorial, maybe in a smoker, but also avascular callus and avascular non-union, which is stable, but has no vascularity at all. Then, of course, we have the classification of aseptic and infected. The principles of treatment. How do we know when to intervene when we see a non-union of the tibial shaft? Well, actually, when the instability is obvious clinically, or we see beginning failure of alignment in the radiology. So the principles of treatment, of course, are stabilization, enhancement of biology, and if necessary, eradication of infection. Now, something is very essential when we're talking about stabilization, meaning we need a mechanical component to allow calcification of the fibrocartilage within the non-union, but we also, at the same time, need to avoid loss of alignment. And usually we have the plating mechanisms, intramedullary layering, of course, but sometimes also external fixation. Let's look at stabilization with plating. We have pros. It's probably the best tool for non-union of the tibial shaft. It can be a single procedure, interfragmentary compression, correction of malposition or malalignment, and we can also use reconstructive measures. But we cannot axially load, so there is usually a longer time necessary for full load bearing. Now, if we look at this is a case I did with Jeff Mast. We have an acute fracture in a tibia with a pre-existing non-union. How would we fix this? The plate usually helps us a lot. Next slide, please. And we use all kinds of methods in order to get not only the tibial fracture, the fresh fracture, but also the non-union under compression, using compression screws, using a plate, and putting both under compression. And after 2 years, you can see the result in the next slide. As you can see, both the acute fracture, the fresh fracture, and also the non-union have been healed by compression. So with plating, we very often use a wave plate for increased local stability placement of autografts. Sometimes we do need autografts, especially in the avascular type. Compression with lag screw or by tension device, and we always have to put the plate on the tension side. Here is a septic non-union that I got at 6 years post-injury. And if you look at the next slide, you can see that there is malalignment in both planes. Now, how to correct this? Well, this was done by debridement, a single very long oblique osteotomy of the tibia, also a single very long oblique osteotomy of the fibula, using a wave plate, secondary decortication, and bone grafting. And at the end, you can see the alignment achieved using a plate. And in the end, at 2-year follow-up, this is post-hydro removal. The patient walks painlessly. He has a very good range of motion, both in his knee and his ankle. And the fracture is healed. There is no sign of infection. So intramedullary nailing, we have pros for that. It's biomechanically actually better because we can axially load it. But we also have other methods, dynamic interlocking for rotational stability, axial compression. But the cons, sometimes in the next slide, please. It can be difficult to pass, and it's always has, of course, a limitation of use in the metaphyseal region. Now, if you look at this on the right side, you see this is a non-reamed nail. Very often you will find that the nail tends to shorten, the bone tends to shorten but not heal. So we have non-union at 8 months with malalignment. So what can we do with this? 4 months after reamed nailing, this is a very standard type of treatment. So the common causes of delayed union in the tibial shaft very often are not only open fracture, but the unreamed nail. External fixation, callus distraction. This is the Alizarov method. We tend to use this in large segmental bone defects. And the big advantage is that we find histiogenesis of both the bone and also the soft tissue. And depending on the type of external fixation you use, you can have a very good alignment control. But of course, it is time consuming. It can lead to joint contracture, and for the patient, it can be very uncomfortable. External fixation with free vascularized bone graft. We talked about this before. Again, for large segmental bone defects, we can use a fibula or multiple iliac crest. And the cons, of course, are we only have a gradual hypertrophy of the bone. It takes a long time for necessary for full load bearing, and it's all very often it can be very hard to hold the alignment. So the principles Enhancement of biology is one of the main things for non-union. Bone graft, cancellous bone graft, is still the gold standard for biological and mechanical purposes. Why? Because it gives you a source of vital bone cells, meaning it's osteogenic. It recruits local mesenchymal cells, which means that is osteoinductive, and it provides for a scaffold for ingrowth of new bone, meaning it is osteoconductive. Decortication, sometimes very often actually used, muscle pedicle bone graft. It enhances the healing response, creating a well-vascularized bed for the cancellous bone graft. Bone graft, bone substitutes, and other substances. We traditionally can use hydroxyapatite, tricalcium phosphate, bone morphogenic proteins, which can be instilled into the non-union. And recently, in the last years, stem cells, mesenchymal stromal cells, actually combined with bioceramics, and this can be read up. Iaquinta in front cell deviation biology in 2019, a very, very good overview. Why do we do these methods? We can use these methods to contribute to the reconstruction of bone cavities due to osteoinductive and conductive capacities of these stem cells. But of course, they also require a vital and well vascularized environment. So what about septic non-union? We find these up to 40% in open fractures. And again, this is time tested, but it's still the correct way of doing things. Debridement of all tissue, all dead tissue, removal of all implants except those that provide stability, because we need a stable situation. A septic bone will heal in the face of stability, but not in the face of instability. Stabilization, external fixator, internal fixator, plates, soft tissue reconstruction, bone reconstruction, decortication, cancellous autograft, free vascularized bone graft, and antibiotics or antibiotic beads. Simpson had a very, very good overview article in the 2019 injury. But in the end, prevention of non-union is the best treatment of non-union by using biological fixation in your original operation. So in order to summarize, next slide, please. Non-unions are the product of disturbed bone healing. This regards to vascularity, instability, and sometimes infection. The treatment principles are time-tested, stabilization, enhancement of biology, eradication of infection. But in the end, if you can prevent delayed unions or non-unions by using biological fixation, indirect reduction methods in the original operation, you can actually help to prevent non-unions. Thank you very much, and I'm sorry for the technical problems that we had.
Thank you so much, Fred, for your comprehensive lecture as always. And the next speaker is my friend from Egypt, Professor Hauseman M.D. Hauseman is Chief of Orthopedic Trauma Unit in Asid University, and he is in National Faculty. He's going to talk about the tibial bone loss, how to treat without circular fixation. Thank you, Hauseman, for joining us and being with us.
Thank you very much, Dr. Muhammad, for inviting me and giving me this opportunity to share you and to be a part in this event. I really enjoyed the lectures of the past session, and I am very pleased to see you and the friends, Dr. Fred, Dr. Walid, and Dr. Khabiri. Please, would you run my pre-recorded lecture? Good evening, everyone. I would like to express my deep thanks to Dr. Muhammad Tuhami and the board of POTA for inviting me to this very important Congress. We are going to talk about the tibial bone loss, how to treat without circular fixation. We are going to list the causes of tibial bone defect, appreciate the critical sized bone gap, and discuss different techniques for reconstruction of tibial bone gap without circular external fixator frame. Most of tibial bone defects result from trauma, especially open fracture, segmental bone loss, post-debridement, and blast injuries. It may result as well from infection or tumor resection. We should address all factors related to bone gap. It's not all about bone. We should address the limb vascularity, viability, function, and host factors as well. It is very important to define the critical sized defect of the tibia needing reconstruction. The definition of critical size defect is a bone defect which is not expected to heal in the absence of a secondary surgical intervention. It was defined in the past as a defect involving 50% of the cortical diameter with a minimum length of 1 centimeter. However, after the Sprint trial, a question mark was put on this definition. There is no consensus about the definition of a critical sized bone defect. However, in the last years, there is a trend to define it as more than 25 millimeter tibial bone gap. How can we reconstruct tibial bone loss without the use of circular external fixator frame? We have many methods. The in situ reconstruction, induced membrane technique, distraction osteogenesis by bone transport or acute shortening and gradual bone lengthening, and salvage procedures such as free vascularized fibula or tibialization of the fibula. For in situ reconstruction, we have different bone grafting techniques. We have the autogenous bone grafting we all use in our daily practice. We have the recently introduced REA. We have also allograft, demineralized bone matrix, bone morphogenetic protein, and bone substitutes. For the REA or reamer irrigator aspirator, we can harvest a larger amount of bone graft coming out of the reaming process, but we should be aware to choose the proper reamer size to protect the femur from iatrogenic fracture. The allograft is one of the grafting techniques that can overcome a large-sized bone defect. It is one of the useful methods in tumor resection. What about induced membrane technique or the musculate technique? It entails 3 steps. The formation of induction membrane after bone debridement. The defect is filled with bone cement. This bone cement will remain for an average of 6 weeks. Then we gently remove the bone cement and we fill the defect with cancellous bone graft. And we use the newly formed membrane as a host for this cancellous bone graft. This article published by Professor Peter Gianoudis and his group, and we report the use of musculate technique to overcome bone defect ranging from 2 to 12 centimeter with an average of 4.2 centimeter. We have this article as well giving some tips and tricks. One of these tips is to use the radiolucent carbon fiber intramedullary needle to fix the tibia and fill the defect with cancellous bone graft. And the idea is the use of this radiolucent needle will facilitate imaging and follow-up of bone healing. We have also reports about the use of cylindrical titanium mesh cage used for spinal surgeries in order to give structural support in tibial bone defects, either diaphyseal or metaphyseal, when we use intramedullary nail for fixation of the tibia. and filling the bone defects again with bone graft. Destruction osteogenesis is still a working horse in tibial bone defects, even without the use of circular external fixator frame. Bone transport or acute shortening and further lengthening can be used to overcome bone gaps. We have this article comparing the outcome of acute shortening to the bone transport, and they report that both techniques demonstrated excellent outcome. However, bone shortening is limited by the risk of kinking the neurovascular bundle, and it cannot be used if the fibula is intact. Here, this article reports excellent to good outcome of using a rail fixation system, a monolateral external fixator frame, for bone transport to fill tibial bone defects. We have this randomized controlled trial comparing the ring fixator to the rail fixator in tibial bone gaps. And we came to the conclusion that up to 6 centimeters of tibial bone gap can be managed by either a ring or rail fixator. But they recommend the use of ring fixator in bone gaps more than 6 centimeters. Again, we can still use the bone transport when we have internal fixation devices like the nail or the plate. We have bone transport over nail. The idea is to use the nail as an internal fixation tool and to put a monolateral frame to have this bone transport. This will reduce external fixator time and allows earlier with Biennial. This is an example of filling a distal tibial bone defect by bone transport over nail. The same can be applied to plate fixation. We can do bone transport over plate for segmental bone defect of the tibia. We should have our preoperative planning site of corticotomy, where to put the external fixator frame. And this is an example of filling proximal tibial bone defect by bone transport over plate. Again, this will reduce the external fixator time and allows free mobilization of the joints and early weight bearing of the patient. We have recently this innovative technique of plate-assisted bone segment transport with motorized lengthening nail and locking plate. The idea is to use the motorized nail in a reversed manner. It will do bone transport instead of the external fixator frame. The pre-lengthed nail will be inserted and then it will be used to exert shortening of the fragment that will translocate the tibial bone segment and do bone transport and fill a distal tibial bone defect. We have salvage procedures such as the vascularized grafts, either a pedicled ipsilateral fibula or free bone flap, and the working horse is still the free vascularized fibula. This is an example of filling large tibial bone defect by the use of free vascularized fibular graft. But we should be aware that it will take time to hypertrophy and there is a risk of fracture of the fibula. We have also one of the salvage procedures, the tibialization of the fibula. It entails medialization of the fibula to fill large bone defects of the tibia. And we have 2 techniques to do that published in this article. We also have the induction of tibiofibular synostosis with intertibiofibular graft for traumatic segmental bone defect of the tibia. To summarize, reconstruction of tibial bone loss, small defects up to 6 centimeter, autogenous cancellous iliac bone grafting, especially with the new REA techniques, up to 6 centimeter induced membrane technique or the musculate technique is working well, although we have reports to use it in defects more than this. up to 10 centimeter destruction osteogenesis, bone transport by rail system, bone transport over nail or plate, acute shortening and the gradual bone lengthening. More than 10 centimeter, we have revascularized fibula or tibialization of the fibula. Our take-home message, it is not only the bone loss, but also other factors to be addressed when we are going to reconstruct bone defects. There are many options for reconstruction of tibial bone loss away from the circular external fixator frame. Currently, there is no robust evidence comparing the different treatment strategies of tibial bone loss. Not all cases can be treated with the same technique in all institutions. It is the surgeon's experience and wise decision case by case. Thank you very much for your attention.
Thank you, Hauseman. Thank you for your lecture. It was comprehensive, it was new and evidence-based, and I hope it will be useful for our delegates all over the country and from all neighbors and other participants from the other country. The next speaker and the last one is Dr. Saeed Khabiri from Seyyed University. He is also executive director of this Congress with all the emails that you have already the views from POTA is done by Seyyed. There is a question also from Osama. Do you expect to change diameter of tibialization of fibula? I think we have enough time at the end to answer this one. Seyyed, would you please continue? Seyyed lecture is a new topic, a question that many patients will ask the orthopedic the surgeon. Will my tibial fracture heal? And thank you, Seyyed. Please start.
Hello, dear friends and colleagues. My name is Saeed Khabiri from Shohada Tajrish Orthopaedic Department, Tehran, Iran. I'm honored to be at the first Biennial International Congress of Persian Orthopedic Trauma Association 2022. I need to mention that in this presentation, I have no conflict of interest. Our subject is after a tibial fracture, the patient may inquire, will my tibia fracture heal? So that a responsible and accurate response to the question may be provided. What is the chance of tibia union given the patient personal condition, fracture type, and surgical procedure? Divination has long been fascinating and essential to humanity. In this regard, it's necessary to consider degree of prediction in addition to the clinical and scientific work we undertake for patients. According to this topic, we can play to identify patients at high risk and provide early intervention if necessary. Despite variance in fracture pattern and patient characteristics, tibia fracture have a 9% non-union rate, and we expect most fracture to heal within 16 weeks. Several risk factors for tibia non-union have been identified in the literature, although the magnitude of their influence, for example, odds ratio or relative risk, varies depending on the type and quality of study design. However, four systems have been developed to predict the occurrence of tibia non-union. The non-unit determination score was introduced in 2016, followed by the fracture healing score in 2018. The lead genuine non-union index in 2019, and the tibia fracture healing scoring in 2020. Which we'll go through in more detail in the following slide. Kevin O'Halloran and colleagues published the first prediction model for the tibia fracture non-union in 2016. This model includes 6 clinical and 2 radiographic criteria, with most of them being binary question. These ratings range from 0 to 21, with score more than 9 the post-operative period, suggesting a high likelihood of non-union. Of course, version 2.0 of the NERD system was recently released and available at www.sharknerd.org. This new version calculates the probability of producing a non-union with a bit of change in the definition of the variables and a change in the method they are analyzed. However, I will note later that others have not yet reviewed this version. In 2018, Professor Leo Masari created fracture healing score system as a part of multi-center and multinational effort. This scale is based on 27 variables shown on the right edge of the screen. The sum of these scores create the patient score, and a number greater than or equal to 8 indicate a higher likelihood of non-union. In a 2019 publication co-authored by the University of Leeds and the University of Genoa, Emanuele Santolini and his colleagues introduced the Leeds Genoa non-union index system. In this model, there are 4 clinical and 4 radiological criteria, and a high score of 4 in the 12 weeks following surgery is specified as a threshold for being highly predictive for non-union. Finally, in 2020, Johan Jan presented the tibia fracture healing score system, which included simple clinical criteria as well as the radiologic criterion, the radiographic union scale in tibia fracture. At week 12, these parameters are considered, and if the score is less than 3, the patient requires additional surgery. An article was published in 2021 comparing this scoring system and analyzing 15 patients who were prospectively and randomly selected among their patients, 5 non-united fracture patients and 10 fracture union patients. This research investigation showed 100% positive predictive value in LEG model and 100% negative predictive value in the NERD model. And in terms of strength, all 4 models are great. And several specifics, however, help to the model in exhibiting their strong qualities. NERD model and LEG system, for example, are simple to use and accessible. Alternatively, LEG may have chosen more consistent patients. But the following are some of the weaknesses. For example, in fracting score, absence of standardized treatment for tibia fracture, lack of any radiographic parameter to assess the healing, absence of clear definition, evaluation at time 0, and so not taking into account essential variables such as infection, and has considerable heterogeneity in patient and surgeon. About 363 patients treated by 79 others of the paper, considerable heterogeneity in patient and surgeon. Leeds and Genoa non-union index weaknesses are it does not account for NSAID use and not specific to the tibia. The study population consisted of both femur and tibia fractures. About NERD scoring system, they were specific to intermedullary nailing and no other method of fixation is studied. 90% of patients were high energy injuries with an average injury severity score of 16.5. Therefore, it does not cover the whole spectrum of tibial injury, such as low injury, evaluated at time 0, so not considering infection. No clear threshold for non-union prediction is reported, and it's important to say failed to predict non-union when externally validated in large cohort like sprint trial. About tibia fracture healing score, pain on manipulation, one of the criterion, is not a reliable indicator. Limited applicability in retrospective studies, and there was stick to intramedullary nailing and no other method of fixation study. However, now that we have discussed the various types of predictive system, we want to answer what can be done for the patient in case when there is a potential for non-union. Methods such as rim and exchange nailing and dynamization and the use of biologic augmentation have been mentioned in the management of problems in which union does not advance as expected, which we call delay union, which we call delay union. However, there is no clear established evidence of their cost effectiveness in the prediction setting. A recent preprint review study assessed a randomized controlled trial of adjuvant treatment in delay union cases and also does network meta-analysis on them. The use of bone marrow aspiration alone or in combination with autologous cancellous bone and platelet-rich plasma was found to be effective in the treatment of non-union in this study. The use of low-intensity pulse ultrasonography and bone morphogenic proteins such as BMP2 and 7 has also resulted in a shorter to union time. Electromagnetic field and extracorporeal shock wave therapy may pose a significant risk of adverse effect. In summary, the usage of LEG and nerve system can be increasingly valuable in identifying patients who require adjuvant treatment. In addition, this system must be evaluated and, if necessary, upgraded and or improved. Additionally, it's preferable to administer adjuvant therapy at the appropriate time and with the most cost-effectiveness manner to decrease the burden of non-union illness on both the patient and clinician. Finally, it's worth noting that we're also preparing study on predicting tibia union using radiographic, clinical, and biomarker criteria, and we would be honored if you could join us. At the end, peace and kindness are something I hope to see spread throughout the world. Thank you very much. Have a good time.
Thank you, Seyyed. Your lecture opened a new window for us as the orthopedic surgeon that it seems in future we need a kind of artificial intelligence for the tool for prediction of the tibial fracture union possibility. By the way, we are reaching the end of our second session, and we have only one question that I don't know what was the meaning of the question. Do you expect to change diameter of tibialization of fibula? I think that it means the diameter of the nail. Maybe.
I think they are asking about the hypertrophy of the fibula after implanting the fibula in large tibial defects. This may be the question. Yes, hypertrophy of the fibula occurs after implantation of vascularized fibular graft, and this depends on the age of the patient, the incorporation of the fibula to the tibia. This means first we need the fibula to be united to the tibia, Then through load transmission, we expect the fibula to gradually hypertrophy in response to the loads applied. And it takes long time, usually from 1 to 2 years, for the fibula to reach its maximum hypertrophy. But fracture during this course is sometimes expected.
Thank you so much. Since there is no question and we are reaching our time limit, I want to thank you all, Fred, Walid, Osama, and Seyyed. And I want to thank also Professor Tawakkoli, Chair of POTA, for giving me this opportunity to have the chance to moderate the session. I hope all the delegates can learn as myself with these distinguished faculty. Dr. Tawakkoli, thank you so much.
Thank you from you, Muhammad, one of my best friends, and thank you from the other lecturer of this session. I learned many things from this useful session. Thank you from all of you, and bye.
Thank you very much, and bye-bye.
Good night.
Good night.
Thank you.
Good night.
Good night. Good night.
Good night. Thank you. Okay, we are going to continue our Congress tomorrow about the foot and ankle trauma and wrist trauma from the 6 p.m. Tehran time. Good night and waiting tomorrow. We'll see you tomorrow. Thank you very much. مرسی.
جوینت آریکس محصولی است فوق‌العاده که حاوی سولفات گلوکوزامین و متیل سولفونیل متان یا همان MSM است. علاوه بر این، جوینت آریکس حاوی سیلیکای ارگانیک برگرفته از بامبو است که به همراه ویتامین C میتواند مؤثرترین مکمل غذایی جهت کمک به کاهش درد و بهبود استوآرتریت باشد. کمک به کاهش تورم غضروف‌ها و ترمیم آنها از مهمترین ویژگی‌های جوینت آریکس محسوب می‌شود که این محصول را برای بیماران مبتلا به آرتروز مناسب می‌سازد. این محصول به دلیل داشتن MSM و عدم وجود سدیم برای افراد دیابتی و دارای فشار خون قابل استفاده است.